You are in the Senate Finance Committee. Today is Wednesday, February 21st. Thank you all for being here. I'm going to read the bill order, but before I do, I want to talk about testimony. Everyone will get 2 minutes, except on a bill that has more than 30 people signed up. So that's bill number 705, and they'll all get 1 minute. So that's a rule that the committee has. So the bill hearing today, we only have 7 bills today. I'm really excited. The bill hearing order today starts with Senate Bill 694, then Senate Bill 703, Senate Bill 701, Senate Bill 697, Senate Bill 633, Senate Bill 791, and Senate Bill 93. So Senator Feldman, are you here? Would you please come to the table and bring your panel if you have one?
Yeah, Madam Chair, I think hopefully Commissioner Brain would come up here as, I don't know if it's Marie Grant is here. Yeah, she is here. And John Crom from HSCRC here at the witness table. And Madam Chair, last week I brought a 2-page study bill, and this is another 2-page study bill. And just a little background, if you'd like me to proceed here with the bill.
Yes.
Just
Senator,
by way of a
please.
little background, we're always looking for ways, obviously, to streamline government, cut costs, particularly during times when we're facing difficult fiscal situation, as is the case right now. And in the prior term, when I sat in this committee, I collaborated a lot with Delegate Pena-Melnick, now Chair Pena-Melnick, on a lot of ideas on the healthcare space. And so this session, Chair Pena-Melnick approached me about cross-filing this legislation with an eye towards, again, streamlining government within the state agencies that focus on healthcare. And so on that front, beyond the Maryland Department of Health, who's represented on the panel here, we have 4 other agencies that operate in the healthcare space. We've got the Maryland Healthcare Commission, which is responsible for coordinating the state's healthcare policy to ensure access to affordable, high-quality healthcare services. It sets standards for providers, hospitals, and practitioners, and administers the state's Certificate of Need program. Additionally, MHCC collects and reports important healthcare information for policymakers, providers, and patients. The second entity in the healthcare space is the Health Services Cost Review Commission, known as HSCRC. That's tasked with setting rates for hospital services with the goal of constraining cost growth, ensuring hospitals can provide care to patients, and supporting the fairness of hospital financing. And then finally, the Community Health Resources Commission, which works to expand access to healthcare services in underserved communities and address health disparities across the state. And actually, that's number 3. And then finally, number 4 would be the Maryland Insurance Administration, which is responsible for overseeing the health insurance industry. So all Senate Bill 694 does is, and this is all laid out in the fiscal note, is it requires the Maryland Department of Health to hire an independent consultant to examine if there's any overlap of statutory and regulatory duties performed by the Health Services Cost Review Commission, the Maryland Healthcare Commission, the Maryland Community Health Resources Commission, and the Maryland Insurance Administration. Number 2, to identify statutory or regulatory duties performed by these entities that may be more appropriately performed by the Maryland Department of Health in order to streamline the work and improve effectiveness and efficiency. And thirdly, examine the alignment of the statutory regulatory duties performed by these entities with the Maryland Total Cost of Care model and the state's participation in the Advancing All-Payer Health Equity Approaches and Development model, and recommend changes to improve efficiency of the commission or agency. Madam Chair, with that background, on or before January 1st of 2026, the Maryland Department of Health shall report to the governor, to the Senate Finance Committee, and the Health and Government Operation Committees the results of the study, identifying if there are overlapping duties, recommending with recommendations with ways to improve effectiveness, maximize efficiency, and eliminate wasteful spending. And we do have 3 witnesses from 3 of the 4 entities I just identified. They've all submitted testimony in support of Senate Bill 694, and they can weigh in. And with that, Madam Chair, I'd ask for a favorable report on, again, Senate Bill 694.
Senator, I see Mr. Stefan here from the
Yeah,
MHCC.
I didn't, yes, if Mr. Stefan would like to, he's certainly part of this bill, and
Okay.
I wasn't sure if he had signed up
That'd be
or was
great.
part of the panel, but yes, Mr. Stefan could absolutely come up here and
Okay,
join.
that's great.
So we'll have all four beyond, I think Mr. Lochner, would have been here. I think he's a little under the weather potentially. I'm not sure.
Who's Mr. Loeffner with?
Well, he's with the Community Health Resources
okay.
Commission. And so,
I thought I
know-
finally had them all straight, but I missed
yeah,
that.
yeah, well, that's kind of the point of the bill. So, that said, Madam Chair, I'll yield to the panel and then I'll take questions after that. If that's
Thank you,
okay.
Senator.
Yeah.
So, Commissioner Brain, would you like to start, or
Sure.
whoever would like to start?
Okay, thank you, Madam Chair, committee members. Marie Grant here on behalf of the Maryland Department of Health. So our role in this look is that we would engage with an independent contractor to take a look and examine all of the things that Chair Feldman just outlined. We think this is a good bill. We think it is timely. Healthcare is complex. I think even as we were just going through, right? We think it's critically important to take a look now as we're heading into this really interesting time where we'll be applying for an evolution of our total cost of care model. We're intending to apply in the first cohort, which would start up in 2026. And so this would give us an opportunity to really have an independent look and examination as we continue to improve our healthcare delivery system. So the department supports this bill. Happy to answer any questions. Thank you.
Thank you, Marie. Who would like to go next? Commissioner Brain or
I'm okay, John, you go.
John? Somebody.
Thank you, Madam Chair and members of the committee. I'm John Crom, Executive Director of the HSCRC. Thank you for the opportunity to testify in support of this bill. The HSCRC and the other independent commissions, the MIA and the department, all have obviously critical roles to play in healthcare transformation and advancing the health and wellness of all Marylanders. Increasingly, this transformation requires the agencies and commissions to coordinate and align our regulatory and programmatic functions. Working together not only enables the efficient operation of our agencies, it helps ensure that the alignment of our healthcare partners, including hospitals, providers, payers, and community-based organizations toward improved population health outcomes and total cost of care savings. So in particular, as Marie noted, CMMI's new multi-state ahead model, which represents our opportunity to build upon the important advancements of the Maryland total cost of care model, will require us to align all of these sectors of our healthcare landscape to achieve common statewide goals. So today, I believe that the commissions and agencies are truly working more closely together than we ever have before. And again, I know that that's necessary to drive optimal impact. An independent study of the functions of the commissions is an important opportunity to really validate our approach and find additional opportunities for alignment. So thank you so much for your time, and we urge a favorable support.
Thank you, John. Who would like to go next? Mr. Stephens.
Ben Stephan, Executive Director of the Maryland Healthcare Commission. The Healthcare Commission also supports this bill. We recognize the importance of always looking for opportunities for greater efficiency and greater alignment. Certainly that role is a key role of the legislative branch of government, and we think this is an opportune time to consider that as we begin the planning process that will ultimately lead, we hope, to Maryland's participation in the AHEAD model in January of 2026. I would encourage the process to go forward promptly, as if this report is released in December of 2025. There certainly would be little time to take advantage of those recommendations and considerations as the AHEAD model will launch in January of 2026. All of that said, I think everyone emphasizes that we understand the need to be efficient and pragmatic and collaborate with our partners, particularly our nearest partners, which are the Health Services Cost Review Commission. We oftentimes work very closely with them to the point of we do have separate front doors, but the key facilities, including the bathrooms and the kitchen, are shared between the two agencies. I think that gives you an indication of the close alignment that we seek. That said, we also recognize that we occasionally disagree. Our focus, particularly in health planning, is on need. Health Services Cost Review Commission also focusing on need and access, but also very focused on cost. And sometimes we need to align those differences consistent with our charges. We too support a favorable report.
Thank you.
Thank you very much, Madam Chair. Just very briefly, Kathleen Brain on behalf of the Maryland Insurance Administration, and we are also here to support this bill. I think mostly what I need to say is ditto. I think my partners have said it very well. We support the idea of taking a time to step back, look at what each of these agencies are doing in this space, make sure that we have all the tools we need to collaborate, and make sure that we're not duplicating efforts. So we think that it's very timely for this study to occur at this point in time, and we ask for a favorable report on the bill.
Commissioner, do you have any additional
No,
comments?
no, I just, if there are any questions.
Do we have any questions from the committee? Does not look like it. It's a good bill. Thank you,
Okay,
Senator.
thank you, Madam Chair. Thank you, the committee.
We have one more person in support. They're not named in the bill, but Pakeen Townsend from MHA.
I'm not even sitting down. Me too.
So that ends the hearing on Senate Bill 694. Our next bill is Senate Bill 705, Senator Hayes. Just a reminder, the sponsor will get all the time he needs. Each of the witnesses will have 1 minute. So I just ask that you honor that time. Thank you.
Yep, and Madam Chair, I'm gonna ask my panelists to join me. Secretary of Health, Ms. Laura Herrera Scott, Insurance Commissioner Kathleen Bahrain, Michelle Eberl, Executive Director of the Maryland Health Benefit Exchange, Ben Steffen, Executive Director of the Maryland Healthcare Commission, and John Crum, Executive Director of the Maryland Healthcare Commission.
Senator, I just want to add, the secretary could not be here, but Marie Grant is here in her
Yes,
place.
a Medicaid budget hearing, Senator. Sorry for the
I'm
last
so
minute switch.
glad that you guys found it a priority to tell a sponsor. I appreciate that. Let's fix that in the past. In the future. Thank you, Madam Chair. Senator Antonio Hayes, for the record. Thank you so much to be here. For those of you who are coming to join me here at the panel, I just want to remind you, as the chair has given us instructions, it's not a suggestion, but a must that we keep within the time. The committee doesn't always look favorably upon people that go over that time. So please adhere to the rules that she's laid out so we could get a successful bill hearing and report. Madam Chair, members of the Finance Committee, I'm here today to testify in support of Senate Bill 705. Senate Bill 705 Access to Care Act aims to increase access to care and promote healthcare equality by allowing more people to purchase their own insurance. Let me say that again. So this is allowing more people to purchase their own insurance through the Maryland Health Benefit Exchange. This legislation would simply lift the requirement that people must have documentation of their legal residency status, expanding potential coverage to some of our undocumented residents who represent some of our most vulnerable populations. There will be no additional cost to the state and federal government, as people would need to use their own earnings to purchase their insurance. The Maryland Health Benefit Exchange was founded in 2011 with the goal of offering healthcare options to individuals and small businesses. This program currently requires eligibility for Medicare or federally sponsored healthcare. This bill would expand healthcare options not only for undocumented citizens, but also low-income families who cannot afford healthcare but do not meet the eligibility requirements for Medicaid assistance. Given the complexity of selecting insurance plans on a commercial market, residents who have limited knowledge about the market and whom English may not be their first language are a serious disadvantage and more vulnerable to fraud. MHBE is proven tool ready to help anyone navigating this complex system. Madam Chair, one of the things that I forgot to mention in my opening, I hope you would consider, as you've heard, I'm encouraging those who come before me to stick within the guidelines. We may possibly have some individuals where English isn't their first language, and so they may need interpretation. So I just please humbly ask of the chair to consider just that barrier in their presentation. And with that, Madam Chair, I urge a favorable report for Senate Bills, I almost said the House Bill number, Senate Bill 705.
Who would you like to go next?
Whoever is so bold to go next.
Thank you, Madam Chair and committee members, for the opportunity today to speak to this bill. Although all residents can currently purchase coverage outside of the exchange offers a number of advantages to consumers. And by the way, I'm Michelle Epperly, Executive Director, Maryland Health Benefit Exchange. First, we offer a simplified streamlined shopping experience. Our users can compare all plans. They can see if their doctors in the network, if their pharmacies or their drugs are covered, and they can use our tools that we have to help the families pick out plans that are best suited for their needs. In addition, we have extensive customer service support. We offer over 200 languages through our call center. We have in-person assistance of brokers around the state, our navigators, and other stakeholders that are there to help. This bill does not subsidize anyone's coverage. It would simply allow individuals who want to take responsibility for their own health and finances to purchase health insurance for them.
Good afternoon, Madam Chair, members of the committee. My name is Kathleen Borain. I serve as the Maryland Insurance Commissioner, and we're here today to support Senate Bill 705. Again, to be clear, currently people are allowed to buy health insurance regardless of immigration or documentation status. This is not a bill about whether or not people can buy. It is a bill about where they can buy. I will echo what has been said about the enormous helpfulness of the tools that are available on the exchange. But I will also say that the Insurance Administration is aware that undocumented communities are particularly ripe for fraud, and we have had to engage in enforcement actions where people have been sold products as though they were ACA compliant products when they are not. The ability to go to a trusted source of truth like the exchange to get information in order to make sensible decisions is a very important consumer protection, and we urge the favorable report on this.
Ben Steffen, Maryland Healthcare Commission.
Get the mic.
The Healthcare Commission also is strongly supportive of this bill. You have my testimony before you. I want to maybe go off in a little different tangent to talk about the numbers. Maryland's uninsured rate for the entire population is about 6%. It's been stubbornly stable. Part of the reason is that 6%, about 375,000 people, about 75% of those are individuals that do not qualify for purchasing insurance through the health benefit exchange today because they are non-citizens. This legislation would provide an opportunity, and we strongly urge a favorable report. We need to lower the uninsured rate in the state. This is going to do it.
John Crom with the HSCRC. The HSCRC also supports this bill because it creates an opportunity to decrease the number of uninsured in the state and provides an important avenue for coverage for a particularly vulnerable population that often has few such options. We would just add a couple points here. Reducing the number of uninsured reduces uncompensated care when uninsured are treated in a hospital, which is very important for our state. More importantly, comprehensive coverage means that people can seek the right care at the right time. Rather than relying primarily on hospitals, covered individuals will have access to preventive and primary care and better management of chronic conditions, which is key to overall improvements in population health. So thank you very much for your time. And again, we urge a favorable report.
Thank you, Madam Chair. Marie Grant, on behalf of the Department of Health and on behalf of Secretary Herrera Scott, let me first say she sends her deepest regrets. We were trying to manage the timing even just not long before we got here, and unfortunately it couldn't work. So I just want to express her support for this important legislation and her role as Secretary of Health, as well as the chair of the Maryland Health Benefit Exchange Board. You've heard all the great reasons to support this legislation. I just want to add at the end that lack of health coverage negatively impacts health. And this offers an opportunity to purchase health coverage in a streamlined way, in a way that supports our communities and Marylanders. And so we urge a favorable report, and thank you, Senator Hayes, for sponsoring this legislation.
Thank you.
Thank you, Ms. Grant. Senator Motz, will you direct your question to a person, please?
Madam Chair, they're all experts.
I know.
Thank you. Very quick, I think, so this would be, okay, I'm going to do a series of questions. I'll get to the right witness. There's one section of the bill says within 6 months, fiscal year, the exchange implements a qualified resident enrollment program. I believe that would be a question for the exchange, correct?
Yeah.
So for the exchange, what are the parameters would you envision around a qualified resident enrollment program? What would those parameters be?
So the parameters will be exactly what they are today for anyone enrolling through the exchange. The only change is that this allows someone who is not documented to be able to utilize the exchange. They also would not qualify for any federal tax credits because that's a federal law. But all other application responsibilities would be the same.
And what would be the residency requirement, or what is the residency requirement?
So the residency requirement is to be a resident of the state of Maryland. And what we do today, documents that we verify. So when someone applies, we ping the federal hub to say, are you a citizen or not? We ping the federal hub to say, what's your income through IRS? If there is not IRS income, then we go to the Department of Labor, the Beacon system, to get state income. All of those have address information on them. We ask for employer information, who the employer is. There's a series of documents that have to be submitted when someone applies. So it would be the same as what we're doing today.
Yeah, and the question I'm getting at, I'm trying to understand, is how would you differentiate between a person who lives in Delaware but claims Maryland? If they have a Maryland driver's license, but they actually live in Delaware, they would be able to qualify if they have an address associated with their payroll, but they actually live in Delaware.
Correct. It would be the exact same as we do today. So anyone who submits their documentation has an address for the state of Maryland. And then, of course, our plans coverage is in the state of Maryland. So, could there possibly be somebody that lives in Delaware and gets all their treatment in Maryland? And pay taxes and have pay stubs? Yes, there could be, but it's a process we've used for 10 years that for everyone who comes through the exchange.
So the verification is your address, your payment, I guess it would be your tax information to verify your residency.
Correct. And we have who your employer is, your pay stub, tax filings. I'm trying to think of what else. But just the demographic information that they put in.
And there's no restriction on age. There's no, the bill has no restriction on age limit. It would be any person, correct?
That is correct. As it is today, if you're not eligible, the only restriction on that today, if you're eligible for Medicare, you're not eligible only in certain circumstances to get coverage through the exchange.
And what federal programs would not be available to someone who is undocumented?
I don't have the answer to all federal programs that
You said there
someone.
was a tax benefit.
Oh, the premium tax credits, which is federal funds that allows those premiums to be reduced, like a child care tax credit. It's a premium tax credit.
Okay, thank you.
Thank you, Senator. Next, we have Senator Lamb.
Thank you, Madam Chair. Good to see everyone again. This bill looks familiar, so I'm glad Senator Hayes has taken up the mantle this year.
Thank you for the sponsorship.
Of course. I guess just a question, because I think Mr. Crom touched on this earlier, which is the fact that anyone that needs care here in the state can still go to our emergency departments and get care. And so these folks that otherwise don't have health insurance are still getting care, oftentimes in not the best environments. Oftentimes they're seeking primary care in the emergency department, which is not a great location. Costs go up. They still have the care that they need to get at that location. We're all subsidizing that in a way, right? And so is the thought here that increasing, while there is cost to this, the value for all of us is that it would reduce the amount of uncompensated care, thus reducing the likelihood that our premiums across the board for everyone, even people that have care, would go up.
I guess I'll answer it since it wasn't directed to anyone. I think you're right on to it, Senator. I think as you know, the emergency room is for, to address emergencies. There's often other complications or other things that individuals require even after the emergency room visit that having access to health insurance would definitely be beneficial as opposed to just, the care to remedy the situation in that moment.
Right. So even the follow-up care is important for these individuals as well, to have some
Absolutely.
continuity of care beyond that. Do we have an estimate of how many people could be assisted by this? How many people that may not be documented that currently don't have health insurance here in the state?
So we know that right now, the estimate of total uninsured in the state of Maryland is about 300,000. We estimate about a third of those are undocumented individuals. Now, again, we don't have any understanding of the uptake of who would purchase because this is a full cost purchasing your health plan.
Mhm.
So we can't estimate how many people would purchase their own coverage.
Got it. But by your estimates, about 100,000 potentially.
That's if every single,
If everyone,
yeah,
yeah.
exactly.
And as far as we know, all those 100,000 are still getting care in some form or fashion because they live here in the state. They're probably using a consumer of healthcare in some capacity.
And what is important to note about that is when you go to the emergency room, the obligation is to get you stable.
Stabilized.
So once you leave that emergency department, you still have that condition, you still have the chronic conditions. The benefit, obviously, of healthcare is the wellness benefits, the preventative benefits to even keep you before you end
And the
up.
continuity too. I guess
the
to Senator
continuity of
Hayes'
care.
point, you may leave with a 30-day supply of blood pressure medications, but beyond that, you may not have anything. Okay. Thank you, Madam Chair.
Hey, Senator. Next, we have Senator Reedy.
Thank you, Madam Chair. If I could ask on just back to the health exchange for a moment. So residency is you have to have obviously an address. What kind of identification do you show to prove the address? Just a driver's license or some sort of form of state issued ID?
So when you submit your application, it asks for your address. You have to submit your social security number if you have one. If you don't have one, an ITN number. Again, we use the federal and state sources, electronic sources, but if we can't verify you, then you have to upload documents, and that could be a pay stub. But we currently do not get a license update unless we need to verify something that we don't have from another source.
So for folks right now that are not citizens but are here legally, they can update an ITN number. Is there any other way that they can get insurance currently if you're if you don't have a social security number, I guess it's a better way to ask that question.
Through the exchange?
Through the exchange.
Today, if you're not a citizen, you cannot purchase health coverage through the exchange at all,
So even if you're okay, all right.
unless you have legal status.
Right, if you have
yeah.
legal status,
Right.
right, so if you're here legally, okay. And if you have legal status, you would have an ITN probably, that's how you would,
Correct.
you would enter, okay. I was looking at some of the testimony in here, Johns Hopkins, I was reading their testimony. So they, and I think you all have cited the number that we have about 275,000 undocumented aliens or undocumented immigrants in the state.
No, about 100, well, I don't know the total undocumented in the state, the uninsured amount, uninsured undocumented, we are estimating at 100,000.
Okay. Because it's interesting to me, the statistics show that from 2007 to 2017, we increased, our undocumented population increased by 45,000, which is the largest raw number in one of the largest raw numbers in the country. And as a percentage is very high. And I'm imagining that from 2019 till now, we've seen an even larger growth of people who are here and they're not here legally. And we understand there's a lot of reasons for that. But as of 2019, that was 5% of the state's population. And now I'm assuming it's a similar percentage or higher than it was 5 years ago. Is there a concern about what is your concern, or is there any concern about having a large group of people that otherwise could not have come to utilize the services now need to come utilize the services from a staffing and a interpreter perspective?
From the exchange
Yeah,
perspective,
from your exchange.
we already employ bilingual folks at our call
Oh,
center.
sure, yeah.
And we all have over 200 languages that we have available. So we don't anticipate the impact is going to be significant. I mean, this is, again, part of our mission is to make sure everyone has health coverage. So we scale for that, whether this year with the public health emergency unwinding, we scaled up in the call center. You know, we can scale up and down as we need to based on what we estimate for that year's coverage
Are
purposes.
certain months, if this bill takes effect, and I forgot to look at when it takes effect, is it October 1? With this, I can scroll down, sorry. This bill takes effect January 1. 26, okay. So you would be ready for there to be a scale up at that point in case there was a supply. But so to say that there's no cost isn't probably correct, because we'd have to be sure that we were properly staffed for this, I think it's fair to say, but the sponsor maybe wants to answer that question.
My apologies, I quoted the wrong date. So this bill takes effect October 1st, 2024. It gives until January 1st, 2026, where the regulation should be adopted.
Okay. So before,
I just didn't want to give.
no,
false
it's fine.
information.
In the meantime, when will people start being able to utilize the service if we pass this bill?
It would not be, we have to first get the waiver
Get
from
the
the
waiver.
federal government.
Right,
So
okay.
that takes about 8 months, I think is what we estimate. And then it would start on the open enrollment period. And so that always starts on November 1st is when we gear up for our open enrollment, because in private commercial insurance, there is that 12-week period of open enrollment.
Right.
So it would be part of our normal operations that we do every year when we anticipate what do we expect we're going to have this year for our open enrollment.
Okay, and then the last thing on residency, there's nothing in the bill, and this could be anybody answers this question, or maybe the sponsor, there's nothing in the bill that says you have to be a resident for a certain amount of time to get this benefit? Because that would be true of anybody that joins the state, anybody comes into the state, you could be a resident for one day and access the exchange if you'd like to.
That is correct. That is how the Affordable Care Act was written.
Thank you very much.
Thank you, Senator. And Senator Hershey?
Thank you, Madam Chair. I could just follow up on that last point. The statement was that you could come into Maryland for one day and be considered a resident and then be able to join into this. Is that accurate?
The intent is that you establish residency here. In that particular case, if you were here for one day, but the intent was you're going to be here, you could apply. I mean, we have a way you can do an affidavit to say, I am a resident and I intend to be a resident.
Okay, so I think concerning then is, do other surrounding states have a program that is similar to this that would allow undocumented immigrants to be able to purchase healthcare?
I don't know the answer to that, Senator, but I would say, considering what needs to go into being a resident, right? You're talking about an individual that are claiming that this is their primary address of residence, who's paying taxes into the state of Maryland, who's presenting a lot of documentation, established residency. It's not like someone's just passing through and say, hey, I lived in Maryland, and then all of a sudden they get health insurance.
Yeah.
You know, in a larger context of things, establishing residency is a process.
Okay, and I do appreciate it, because that is what the concern I think would be,
Yep.
is that you
I
have
get it.
somebody, you know, and again, I'm not against making sure people have healthcare, and we've had this discussion in my
Yep.
office as well too, but I do want to make sure it's not being taken advantage of either, if no surrounding states are doing it, and if the establishing residence process is not as robust as it might sound here today, but that there really are some requirements that you have to do to establish residence. You know, we haven't talked about utility bills. We haven't talked about rent, you know, leases. We haven't talked about any of those kind of things. We've just said, you know, you can say that you're a resident is what's a little concerning, but I think we talked about that issue enough. I do want to ask, obviously, how this is possible is that we've been able to drive down the rates so that they can be affordable. And Senator Lamb mentioned that we do not want to see our emergency departments overutilized when they don't have to be. You know, that we've all agreed that is probably the most expensive form of healthcare that's out there.
Yeah.
But you did mention that the emergency department's requirement is to stabilize somebody. If an individual goes into emergency department without insurance, they stabilize them, they send them back out. What happens next if an individual does not have insurance?
You want to ask the residency one first?
Why don't you go ahead and answer?
And so, unless someone else want to answer, essentially they go and stabilize, but they're still left with whatever chronic condition or whatever to deal with over a period of time, which oftentimes lead them back into another visit into the emergency room, which we all already agree is the most expensive option.
Okay, so, and that's what I was thinking as well. So if we are trying to make sure everybody has insurance, we're trying to find obviously a way, we've driven down the rates. Are the rates affordable because of, like, for instance, we've done the reinsurance plan? Is that what's helping to make these rates affordable as well too?
So the reinsurance program has resulted in the reduction of rates substantially.
Right. And that's what the benefit exchange can utilize and drive that. The rates are, the programs that you have in place that are affordable is because of the reinsurance as well too.
It is, but that's not unique to the exchange. So
No.
that is by market. It's the entire individual market, regardless of where you buy your insurance. So undocumented people can go buy health insurance today.
Mhm.
Their rates are influenced by the reinsurance program, and their claims are subject to indemnification through the reinsurance program. None of that is different.
Right.
This is just about whether they can use the navigational tools in order to buy the health insurance.
Mhm. And in doing that, does that find them being able to purchase plans at lower premiums? Is that the goal?
No,
as
the
well, too, or
premiums
not?
are not different between,
Okay.
so every plan that every health insurer in the state has to offer product on the exchange. They may also offer additional products off the exchange, but the costs are the same for on exchange and off exchange products.
Senator Hershey, the difference is buying it from the commercial market versus buying it from the exchange. You have all these extra additives like the navigators and other things that help you through that process. I think the insurance administrators so eloquently articulated, you know, this is a population where English may not be their first language. And I've heard, you know, even talking to the vice chair of HGL who attempted to go through and look at the commercial market herself, it's very complicated. It's not, even for individuals where English is their first language, it's really hard to navigate. And so having the benefit of the exchange that provide these other, this extra level of assistance to walk you through it is simply the option that we're asking for today.
Okay. All right, that's fine. Thank you very much. Thank you, Madam Chair.
I want to take your comments a little bit further. Senator, because there was a time that I sold health insurance.
Yep.
And it is very difficult. So you have people who don't speak our language calling one company and getting a rate, calling another company and getting a rate, but it's not the same coverage. And they call another company and it's different coverage again. And I think what the exchange does so well, besides the navigation, is the languages. As you said, over 200 languages, so people can find help from a navigator that can speak the language they understand on a subject that most of you, your eyes glaze over when we say insurance. So I don't think it's any different for the constituents that we're trying to help. So I just want to particularly thank Ms. Everly for the work that she does with the navigators and all the available languages. So thank you. I don't see any other questions. That ends this panel.
Thank you, Madam Chair.
And Senator, stay close because you have another panel coming up, just in case there's more questions.
Oh, man. Thank you all. Appreciate it. No, thank you.
You know, if you just maybe stay in your seat or at the podium, that's fine. That's fine. I just didn't want you to go testify in another committee yet.
Yes, ma'am. Thank you. I do have another bill and another.
I know, and just to explain to people why we have seats open, people are in other committees testifying on their own bills. And so you'll see coming and going, and we're not outside having parties. We're in other committees. Pegeen Townsend, Sally Ann Alborn, Pam Casemeyer, Robin Elliott, Monica Guerrero Vasquez, and Dr. Nelson Malone. That's our next panel. So whenever you're ready, somebody can start.
Thank you, Madam Chairman. Peggy Townsend on behalf of the Maryland Hospital Association in support of this bill. The previous panel clearly articulated many of the reasons why this is a good bill, but I just want to emphasize a couple of things. Not only do undocumented come to the emergency room to get care, but they come sicker. So it's actually more expensive because they've delayed care. And that means they're sicker, requiring more care in the hospital. The second point I want to make is the navigators. This is really, really helpful for people buying insurance. I don't care if it's English is your first language. It is really hard to buy an individual policy on the commercial market by yourself. These navigators, as they're called, or this exchange has become known as the source of truth, so that it's very clearly understood. You can compare, you can figure out who's in network. I mean, it's very helpful. And then the translators, as you said, Madam Chair, very helpful for this specific population.
Good afternoon, Robin Elliott. I'm here today on behalf of the Maryland Nurses Association and the Maryland Assembly of School-Based Health Care. We also have a lot of clients. You have our written testimony across the board support this bill, which does just allow people to use their own earnings to purchase health insurance. I just wanted to highlight a particular group of people who this bill will help. The school-based health centers we have 90 of them across the state, all the way from the Eastern Shore, Central Maryland, up to Montgomery County and Frederick. School-based health centers see a lot of children who are here legally. They may be citizens because they're born here, but one or both of their parents are not here legally. And in that case, a lot of times, even though those children are technically very much eligible for Medicaid, the parents have not gone through the process. So by opening up access for the parents, we are also ensuring more children will be covered. Thank you.
Who wants to go next?
Madam Chair, Madam Vice Chair, thank you for the opportunity to speak to you this afternoon. I'm Sally Alborn. I'm the CEO of Maryland Community Health System. It's a network of 7 federally qualified health centers with 55 care delivery sites throughout the state. I am also a nurse with 60 years experience as a clinician, as an insurance executive, and currently as a healthcare administrator. As many of you know, federally qualified health centers provide primary care services regardless of a person's ability to pay. However, when a patient needs x-rays, treatment, or specialty services, we have nowhere to go. We have nowhere to refer that patient. Likely, that patient will end up in the emergency room and or the hospital, probably sicker than when we saw them as a primary care patient due to a lack of treatment. Thank you for the opportunity to support this Senate Bill 705.
Who's next?
I think I am next. Madam Chair, honorable members of the committee, my name is Monica Guerrero Vasquez. I'm an immigrant Latina, Executive Director of Centro Sol, the Center for Health and Opportunities for Latinos at Johns Hopkins. My colleagues at Centro Sol and the Johns Hopkins University in Medicine urges favorable support for the Senate Bill 705. The only difference between me and Maria and Julian, who are from Mexico and have been living here in the US for 15 years, is that they don't qualify for health insurance to purchase her health insurance through the Maryland Health Exchange. That platform has allowed many people in the state to acquire health insurance, and the rates have decreased tremendously in the state. However, undocumented immigrants are not allowed to purchase their insurance. I urge the committee to favorably support this. It will reduce costs, uncompensated costs. It will increase equity in the state, and it will build a more diverse state. Thank you.
Hello, Madam Chair, members of the committee, Pam Casemeyer here on behalf of a number of clients as well. Wanted the Mid-Atlantic Association of Community Health Centers, most notably because they do have a very large immigrant patient population, often because they're uninsured or low income, and they do see people regardless of their ability to pay. And as Ms. Alborn referenced, that is a big challenge for them. I'm going to say me too. I'm here from MedChi Academy of Pediatrics. I'm going to say me too, because I think you've heard most of what we had, but once again, reaffirming the importance of the navigator services. I wouldn't know how to go and buy my own insurance if I couldn't talk like through the navigator services that the exchange had. I don't know how anyone could, especially if they have language issues. So we would urge a favorable report.
And hello, Chairwoman Beadle and esteemed members of the Finance Committee. My name is Dr. Nelson Malone. I'm a current emergency medicine resident at Johns Hopkins and also hold a master in public health with a true passion for health equity. I'm here to strongly urge you to support Senate Bill 705, which would increase access to healthcare by allowing these residents access and additional resources to help facilitate that process. We've talked a bit about this, but I do just want to echo sort of the impact of when there isn't coverage to these primary and preventative services, they oftentimes do end up in the emergency department where providers like myself are happy to care for them, but they truly deserve and need those wraparound services once they leave. And like you said before, they often come in sicker because they don't have those to begin with. So I strongly urge this committee again to support Senate Bill 705, and thank you for your time.
And Madam Chair, just for the record, Dr. Nelson is my intern this session. Although he works at Hopkins, the views that he represents are his own and not that of Johns Hopkins University.
Yes.
What he said.
Yeah.
Exactly what he said.
Thank you. Senator Washington, do you have a question?
Thank you, Madam Chair. On the previous panel, I guess there was some questioning and confusion that I had about the answers. If we have more people going to the system, I heard that it would decrease the costs, but then I heard that it won't decrease the cost, the rate in which they pay, the person's pay. Can someone just clarify for that? If we have more people join, will that then decrease the cost of care per rate per person? Or will that, well, just give me an answer to that.
The answer is yes. So essentially, the larger your insurance pool is, the lower the cost is for everybody. And as I spoke about the families who want to purchase insurance, those are young families. We want to insure those people because it lowers costs for everyone.
So then does that mean that if we have the lower premiums, does that mean that everybody's cost would go low immediately once everybody joins? like, will Marylanders that are currently in the exchange see a decrease in their rate?
So yes, there's always like a
I've
time lag
never-
when these
I've-
things are calculated. But essentially what we're doing by increasing the pool is we will see lower premium increases in the future. So it's not necessarily our premiums will drop, but the growth will not be as great because we'll be insuring more people.
Okay, so
And more-
rates will still increase, but it'll increase at a not 5% or 15%, maybe 2%, for instance.
I'm not an actuarial.
Hypothetical.
Hypothetical, right, yeah,
Yes.
right. Okay, so I mean, because I wanted to clarify that because I've never met an insurance company that wants to decrease premiums. So that would be the first I've heard of it. So, but thank you for answering my questions.
Senator, actually, there's another bill today that you'll hear that may answer some of your questions. Thank you.
Young grasshopper.
Senator Reedy.
Thank you, Madam Chair. Yeah, so that's a great line of questioning too, because a lot of times we use the word care interchangeably with insurance. And of course, obviously, insurance enables people to get care that they might not be able to. But one of the questions I have, and as I keep looking at these numbers, is I understand everybody that's spoken today, the motivation behind wanting to help people that need health services. I think the challenge that we have to look at is our state has done a whole lot in the last 20 years to become a place where we attract people who are here in an undocumented fashion, both with state policy and also with certain types of policies in some of our counties and cities. And when you say it's not going to add, it might help bring premiums down, or not down, but might help get the pool bigger, which is the concept behind the whole exchange. Number one, are we saying that the groups of people that are currently undocumented and uninsured are because if they're real healthy, then that might be true. If they're not particularly healthy, and I have no idea, I'm not casting aspersions here, that wouldn't be true. And then number two, when we talk about care versus insurance, we already have a huge shortage of health occupations and a shortage of access to care for people who are currently our citizens and taxpayers. So what can anybody on this panel say to me to help me? Because I think we need to be very honest that the fiscal note may say whatever it says, and this is certainly better than just giving everybody Medicaid, which was last year's bill. But this is not going to be cost-free. And it is going to continue to make Maryland a destination for people who have not followed federal immigration standards and laws. So I don't know who would like to comment on that.
Yeah, I don't know who from the panel would like to jump in, but I'm not an immigration lawyer, nor do I play one on television. But I will say this will give an opportunity for individuals who are undocumented. There's a lot of different things in which they're referred to, and I get lost in the legality of which means which. But this will allow individuals who are undocumented, who are more likely working here in the state of Maryland, that definitely reside here in the state of Maryland, an opportunity to purchase, right, healthcare on our exchange. I think part of the testimony that we've already laid out already is these individuals have the opportunity now to get, healthcare, but in getting the healthcare, especially on a commercial market, is complicated. This allows them to purchase on the exchange because of this legislature and all that we've done in working with the good folks over at the exchange has safeguards to make sure that it's a reliable system that individuals will get taken care of. Also, to your point about like the people that are more healthy, having healthcare as opposed to entering the emergency room helps with all of those things that all of us enjoy, like preventive care, to help us from getting sicker in a process. And so, although individual, I think the testimony that you were referring to earlier, a lot of people that come into the emergency rooms, are among the sick. But if they had access to insurance, having the follow-up care, having access to preventive care, and all of those things that encompasses having health insurance creates an environment where we have, in the long run, healthier people in our system.
Thank you for that. I appreciate it. Just the point I think that remains is just a question of the overall system, and access is still going to be a challenge. But I do understand your point. Thank you all very much.
If I may, one point there, may I make
No,
a?
we don't debate. Thank you. Thank you, Senator.
Okay.
Thank you. So that ends your sponsor panel. I'm sorry. Senator Mounts, you have another question?
Thank you, Madam Chair. And just based off that discussion, this topic, and this may be the wrong panel. I'll maybe ask the sponsor, do we have an actuarial understanding of what the cost would be to get insurance? I guess that would all depend on the individual. They have to factor into, I guess, Robin, because you're not nodding your head the hardest. So in order to try to estimate, the participation effort that would be required, what it would cost to participate, that would all be determined by the exchange.
Hey,
Right?
Senator, I'm gonna ask Robin to address it, but if you also don't mind, if you're not satisfactory in the response that you get, if we could have the insurance administrator follow up with you with some, she's already left the panel, but if she could come back and provide some more in depth, if the answer provided isn't satisfactory.
Let's just save the time and I'll do that. We'll just talk about that after.
Excellent. Thank you so very much.
That ends this panel. Thank you, Senator.
Thank you, Madam Chair.
Our next panel is Heather Iliff, Joseph Wynn, Matt Chalentano, Allison Taylor, Frank Patinella, and Howard Lee. Looks like I'm short one. I'm gonna call it one more person. Ria Aurora. Ria, are you here? Come on up. As the Price is Right says, come on down. Who would like to start?
I'll start. Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Kaiser Permanente sells individual and small group plans on the exchange and also off exchange. We currently work with CASA to provide coverage for over 11,000 undocumented immigrants in the state, and wanted to say for the record, we welcome anyone who'd like to purchase on insurance coverage through Kaiser. I can personally attest it is right. It's hard to navigate even for health insurance lobbyists. So there's some real value to the service that they provide for sure. So we urge a favorable report.
Good afternoon, Madam Chair, members of the committee. Joe Nguyen. I'm the Executive Director of the Maryland MCO Association. We're here in support of Senate Bill 705. We believe the bill creates additional pathways for people to buy insurance about appropriate care and appropriate settings. And we believe the access to more preventative care and primary care will keep people out of emergency rooms. And very brief comments, we support the bill.
Good afternoon. My name is Howard Lee. I'm a medical student at the Johns Hopkins University School of Medicine, and I lived in Baltimore for the past 2 years. I'm here to testify in support of Senate Bill 705, and the views expressed here today are my own. During my time at Hopkins, I think most pertinently, I have helped 2 asylum seekers with all of their health navigation, including insurance navigation through the Sally Woman Enterprise. It is from this specific firsthand experience that I've come here today to really emphasize how important this bill is for necessary and accessible healthcare for our most vulnerable in Maryland. I have one story that I hope to emphasize. So on a Sunday morning, I received an urgent call from one of my clients, a middle-aged mother, a Spanish speaker, and an asylum seeker. It was clear she was experiencing a medical emergency with acute severe chest pain. However, instead of calling 911 like most of us would in this room, she decided to call me to ask how she would pay for her ambulance, her emergency room visit, and the subsequent costs. While her very life was at risk, her concerns were financial regarding her insurance status, and it's clear that this well-founded fear of financial burden delayed her care and threatened her life, and she's still struggling to pay for that bill half a year later. Thank you so much.
Good afternoon, Madam Chair, Vice Chair, members of the committee. My name is Ria Aurora, and I'm a first-year medical student at Hopkins, and I'm testifying today in support of Bill 705. Senate Bill 705 addresses critical health disparities faced by the immigrant community in Maryland. My testimony today will make 3 points. First, I have seen with my own eyes the need for this legislation. Prior to starting medical school, I was an undergrad at Hopkins and worked with Latino families to connect them to community-based resources. After college, I served as an AmeriCorps Fellow in Washington, D.C. at La Clínica del Pueblo. Seeing the disparities in access to care between my clients in D.C. and Maryland with accessing health insurance mobilized me to testify last year in support of this bill. This legislation makes it more likely that people will hear about insurance from exchange navigators. More families will benefit from the ease of access and the protections of purchasing insurance on the exchange. Third, my fellow students want their voice to be heard. Enclosed in my hand is written testimony for more than 100 medical and public health students at Johns Hopkins and the University of Maryland in support of this bill. It includes specific stories from 30 students. I hope you will read what we have to say regarding the importance of ensuring equitable care. These are our experiences. We are your future physicians, public health professionals, and healthcare workers. We urge a favorable report for Senate Bill 705.
Rhea, I'm going to listen to your recording and I'm going to slow it down. You got it all in. Thank you. Matt?
Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers in support of Senate Bill 705. And I will say that my eyes do not glaze over when we talk about insurance. So I am happy to be here today to support this bill. Since the passage of the Affordable Care Act, we have made tremendous strides in covering the uninsured in the state of Maryland. We've about halved that level of uninsurance, and that does directly to less uncompensated care, which directly leads to slowing or bending the cost curve in a positive direction on rising premiums. For all those reasons, we support this bill. Thank you for the opportunity.
Good afternoon, Madam Chair, Vice Chair, members of the committee. I'm a senior policy advocate with the ACLU of Maryland, and just here to say us too. Thank you.
And you're Frank.
Yes.
Thank you. Thank you for that testimony. Do I have any questions for this panel? I don't see any questions. Thank you all very much. And thank you for sticking to your time. I appreciate it. Next, we have Marcelina Kubica, Madeline Martinez, Juliana Valencia Banks, Nashona Kess, Ramadan Ahmed, Tara McCaffrey. You can begin as soon as you're comfortable. Thank you.
I guess I'll go ahead. Good afternoon, everyone. For the record, my name is Madeline Martinez. I'm the Assistant Advocacy Director for Catholic Charities of Baltimore. I'm here today, not just on behalf of Catholic Charity, but also as someone who used to process Medicaid applications for a living. As a result, I have experienced firsthand what it's like to process an application where children are eligible for Medicaid, a father is eligible for a qualified health plan, but the mother is not eligible for anything else. I've seen people ask me and be willing to make financial sacrifices so that their loved ones can afford insurance. And I also believe that the Maryland Health Benefit Exchange is a tool that has the capacity to transform how people access health insurance in the state. There is the capacity, as long as there is commitment, to allow people to make purchases and to allow people to be fiscally responsible for their care. For these reasons, I'm here in support on behalf of Catholic Charities for SB 705.
Good afternoon. My name is Juliana Valencia Banks. I serve as Baltimore County Executive John Olszewski's Chief of Immigrant Affairs. In the 2 years that I have had the privilege of serving immigrants across the state, the number one issue that they have asked me about is healthcare. I will not bore you and repeat facts and numbers that you have at your hands. What I will do is remind you that behind this bill are families. Families that have chosen Maryland as their home. Families that are contributing to the financial well-being of our state. Families that are starting businesses. Families that are paying taxes. Families that make our state better. While your counterparts in DC cannot make common sense solutions to difficult problems, you can. There is no reason a child should sit in school and not be able to read the board because they don't have glasses. There is no reason a child should not be able to play sports because they don't have health insurance or worry about the well-being of their parents. For this and the reasons my colleagues have outlined, I ask that you grant a favorable report on Senate Bill 705. Thank you.
Who'd like to go next? All right, Marcelina.
Hi, good afternoon. My name is Marcelina Kubica. I'm a third-year medical student at the Johns Hopkins University School of Medicine, and the views I'm expressing are my own and do not necessarily represent those of Johns Hopkins. I really just wanted to drive home this conversation we've been having about what this exchange would mean for these folks. So already, what a lot of new migrants, asylum seekers, undocumented immigrants are facing is a lot of social determinants or drivers of health. And these can be anything such as transportation to clinic appointments or language barriers, which I know many have already brought up. This is just another barrier to allowing folks to be able to access and successfully navigate purchasing healthcare. And I think any tools we have in our toolbox to really lower this for folks is incredibly important to offer them. I once worked with an asylum seeker who was navigating a financial application to help cover an emergency department bill for her daughter. The stress of navigating just that prevented her from presenting to care to the emergency room when she was having a life-threatening reaction to a medication of hers. And so I think this really speaks to how helping navigate can really help also lower these drivers and determinants of health. Thank you so much.
Hello, my name is Ramadan. I am a medical student at Johns Hopkins, and I'm also an immigrant that was born in Wajir, Kenya. Growing up, I grew up in a large immigrant community. I have had a lot of friends whose parents were undocumented, who have delayed care. They lived in this country for decades. They raised kids in this country, and they still could not get care. Right now, the status quo of Maryland is that we have an environment compounded with low medical literacy that fosters an environment where the most vulnerable in our state are taken advantage of. I sincerely urge you to take a favorable stance on Senate Bill 705. Thank you.
Good afternoon. My name is Nashana Kess, the Executive Director for the NAACP. We stand in favor of this bill to increase health care for all who need health insurance. Look, this bill is not asking Maryland to pay for insurance for these individuals. This merely provides access to the ability to have choices, to weigh the cost of insurance plans, and these allow families to compare how these plans will be best fit for themselves and their families. This will prevent these individuals from causing a bottleneck in the emergency room for health concerns that could have been addressed with their primary care physicians. Like many others, I've been to the emergency room where there are lengthy waits for those with non-emergencies and many times lengthy waits for those with emergencies. This bill is not complicated. Immigrants deserve a choice in healthcare. Their healthcare is important because they are human, because they live as residents of this state, and healthy individuals contribute to a healthy society. We urge a favorable report on this bill. Thank you.
Thank you. And I think finally we have Tara.
Hi, my name is Tara McCaffrey. I'm a medical student at Johns Hopkins University School of Medicine, and the views I represent today are entirely my own and do not necessarily reflect that of Johns Hopkins healthcare system. And I stand in support of the SB 705 Access to Care Act. Similar to what Marcelina was saying, we have a program where we help support asylum seekers in navigating the healthcare system and gaining access to various resources. And as medical students who are trained in the healthcare system, I personally have even found that difficult. And so not only was the asylum seeker I was working with the past year in immense physical pain and facing many health issues, they had the inability to navigate this insurance program on their own. And anything I think that can help alleviate these stressors on top of the social and physical stresses they face is an incredible and easy task and a win.
Thank you. I don't see any questions, but I want to comment for all of you that are currently in medical school here in Maryland. Thank you. And I hope you stay in Maryland because we really need you. So thank you for being here and testifying, and thank you for your work. So the next panel is Amy Parampil, Delilah Friel, Cindy Colade, Michael Huber, Ashley Tentons, and Jonathan Coe. Someone can start as soon as you're ready.
Good afternoon, Chair Member and Chair and member of the community. My name is Cindy Colade, and I am the CASA Baltimore Health Navigator and Social Services Manager. And I am an immigrant from the Ivory Coast. I respectfully urge the committee for a favorable report of Senator Bill 705. As a DACA recipient myself and as a health care professional, I understand firsthand the hardship of not having access to healthcare, as well as the complex process of getting care. Where it is not for my employer-based healthcare coverage, I too will be unable to comprehend the complex nature of the private health insurance market and will be unassured. SB 705 is a game changer for many, including thousands of DACA recipients who don't have access to care. The healthcare system is quite complicated, therefore having access to the exchange plethora of resources, including navigators that guides through the process and showcase simple cost comparison between plans is crucial to coverage. Thank you.
Hi, my name is Delia Friel. I grew up in Montgomery County and I now live in Baltimore and a medical student at Johns Hopkins. Similar to others, I represent only my own views. And as a medical student, I've been fortunate enough to be involved in the Refugee Health Project through our school. And I just wanted to share kind of one story today to reiterate many of the same points. I think I remember listening to one woman's story. She's a recent immigrant seeking asylum right now and doesn't speak English, and talked about the daily struggle of trying to find affordable care in Maryland particularly because she has a chronic condition. And I felt just this immense disconnect between sitting in this classroom right next to one of the most well-resourced hospitals in the world, and my own community member who was unable to go to Hopkins for preventative care. And so she also described having to wait until her situation deteriorated enough to seek care at the emergency room. And I think these are real stories that we need to keep in mind. Thank you so much, and I urge your support for 705.
Good afternoon, Madam Chair, Vice Chair, and committee members. My name is Amy Parampal, and I'm also a first-year medical student at the Johns Hopkins University School of Medicine. I am testifying today in support of the Access to Care Act, and the views expressed here are my own. I have witnessed firsthand as well the adverse consequences and health disparities that stem from inaccessible healthcare. Earlier this year, I met a young man with a neck tumor who had held off on seeing a doctor until he could no longer swallow. When the physician asked him why, he said he was worried about not being able to afford it. He also couldn't afford to skip work for treatment. And a choking episode which nearly killed him is what finally pushed him to seek help. In that moment, I felt helpless, knowing that he and many patients like him are barred from receiving care, often until it is too late. This common sense legislation is uncontentious and aligns Maryland with its values of protecting life and treating all people with dignity, respect, and care. I think back to my time working in healthcare back in my home state of California, where undocumented immigrants of all ages have access to comprehensive healthcare. As a future physician and current resident of Baltimore, I wish for this for all the people of Maryland as well. Thank you for your consideration.
Hello, my name is Ashley Tudens, and I'm also a medical student at Johns Hopkins School of Medicine. Again, these are my own views. I was also a member of the Refugee Health Partnership group mentioned previously, and I would just like to share a story about an asylum seeker that I worked with. When my client arrived in the United States, he did not have much with him but his physical being. And unfortunately, because of things that he had experienced, his physical being was failing him. He could not run as he had once loved to do. He could not eat, he could not sleep, and he had extreme chronic pain. Fortunately for my client, he was part of an organization where we were able to support his medical care costs. We were able to get an imaging study to find out why he was having difficulty eating. We were able to resolve an infection that left untreated often leads to cancer. By the end of the term, our client was a whole new person. For the first time, I saw him have hope. I saw him develop dreams, and I got to see a glimpse into how life must have been for him in his home country. I find it hard to imagine him making this transformation if he did not have access to the care that was covered by the program that he was a part of. As a future physician, I'm here to advocate for the passing of SB 705 to ensure that all my patients, whether immigrants or not, will have access to transformational healthcare just as my client did. Yeah.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Jonathan Kuo, and I'm a first-year medical student at Hopkins. The views expressed here are also my own. My testimony today comes from 3 years of experience as a certified enrollment counselor helping low-income immigrant and undocumented communities in the California Bay Area navigate their insurance options through their health benefit exchange, as well as my recent experience here working with similar populations at a federally qualified health center. What I really want to make is one point, and I want to emphasize that from my years of experience working with patients, the most important thing I've learned is that even incremental change can dramatically impact people's experiences navigating these health insurance systems. Health insurance is confusing, and these populations will have other things to deal with. Pages and pages of applications for social support, hours on the phone, difficult times trying to figure out phone lines and places to call. But this will give patients access to plans that are a little less confusing than those on the commercial market. It will let them access navigators who can give them guidance tailored to their best interests. It will help some of the most vulnerable populations in the state and in the country, and it does so for the low price of $0. I urge you to submit a favorable report of SB 705. Thank you.
Thank you all very much. That ends this panel. I don't see any questions. Thank you. I'm going to go back and see if Heather Iliff came in. Michael Huber, Heather, you're here? Thank you. I don't see Michael Huber. And then Tatiana, and I cannot say your last name. Is Tatiana here? Very good. And Alvina Pan. This is our last panel of favorable witnesses. You can start when you're ready.
Thank you so much, Madam Chair. My name's Heather Iliff, and I'm President and CEO of Maryland Nonprofits. I appreciate you giving me a second chance to come up. I was across the hall for the Fair Share for Maryland Act. So I'm representing today Maryland Nonprofits as well as Maryland Latinos Unidos, which is a network of 300 organizations serving Latinos in Maryland, and the Maryland Association of Resources for Families and Youth, which pays attention to the children in the child welfare system. Nonprofit organizations are often picking up the pieces when people don't have access to basic services, and it has a direct impact on their ability to come to our programs for workforce development or language acquisition or their children working in schools. So most of my testimony are things that have already been said today, but I just want to say that when basic needs like healthcare can be taken care of, we can get people into the workforce, contributing to the economy and making Maryland a better place. Thank you so much.
Thank you, Heather. Who's next?
Okay. Hi, my name's Tahitna Temfisu, and I'm a first-year medical student at the Johns Hopkins School of Medicine. Again, the views are my own. I've been a resident of Maryland for the last 15 years. My family immigrated from Ethiopia in 2009 to Rockville, Maryland, seeking political asylum. As a first-generation immigrant myself and the daughter of refugees, I've encountered firsthand how difficult it can be to navigate a healthcare system. And even with English language proficiency and it can be really difficult to connect with the right healthcare providers and understand the billing system. Giving undocumented immigrants access to subsidized insurance would be extremely valuable in helping bridge this difficult gap. And that's why I'm testifying here today. Growing up in Maryland and training to be a physician in Maryland, I want to be in a state that allows all members of my community to receive affordable healthcare. And that's it. Thank you.
Good afternoon. My name is Alvina Pan, here to speak in support of SB 705. I've lived in Maryland my whole life. I was born here, right here in Annapolis. I went to the University of Maryland for college, and now I attend Johns Hopkins University, hoping to one day serve my communities as a physician. So I worked as a medical assistant at a federally qualified health center in Montgomery County all 4 years there at undergrad. A medical center dedicated to serving the uninsured and low income. We never asked our patients about their citizenship status, hoping to serve as a safe haven. But it wasn't enough. I've seen a pregnant mom having a first trimester bleeding refuse to go get an ultrasound out of fear. I've seen these members of our community forego screenings, medications, and other essential medical care for the sake of cost, lack of transportation, difference in languages, impossible number of barriers. And as we talked about, the effects of deferred healthcare will be felt in many ways, cost being a major one. Hospitals and emergency departments are expensive. Schools will feel the impact of sicker children. I work in a school-based health center, and the children are terrified for their parents. SB 707 addresses these health concerns in a critical way. As a future physician in Maryland, it is my responsibility, as it is yours, to fight for our most vulnerable and to close this uninsured gap. Thank you.
Do I have any questions for this panel? Senator Owen.
Yeah, thank you, Mr. Chair. What's your name, ma'am?
Alvina.
Alvina, and you're a student at Johns Hopkins?
Yes.
Okay, so I don't want you to get in trouble. You didn't do the disclaimer.
Yes, sorry. These views are my own and do not necessarily reflect those of Johns Hopkins University. I apologize.
No.
I want to get as much in there as possible.
I know, yeah, thanks.
Thank you.
Thank you, Senator. Thank you all very much. That ends this panel. And now I'm going to bring up our only three unfavorables. So you all can go. You don't want to sit next to your opponents. So I have three unfavorables: Howard Killian, Deborah Hill, and Mary Fry. Oh. Oh. Yeah. Let's start with Howard, please.
As a Mariner and a U.S. citizen, I cannot support SB 705. My name is Howard Killian, and I worked for the state of Maryland for 31 years. I earned and paid for my health and prescription benefits. But in 2011, the General Assembly eliminated our prescription coverage, and we were never told until 2018. The state retirees were told that the prescription coverage was eliminated to keep the AAA bond rating. Has the AAA bond rating changed in the last 5 years? But the state of Maryland will be spending state and federal taxpayers' money to fund health and prescription coverage for non-U.S. citizens. Please explain to me how SB 705 will not also affect the state bond rating. Please also explain to me how non-U.S. citizens can afford health and prescription premiums without having a green card to work. Therefore, we as state retirees are being left behind to fund the U.S. non-U.S. citizens' health care. Therefore, I am and other state retirees cannot support SB 705. Thank you.
Thank you. Next, we have Deborah Hill.
Hello, my name is Deborah Hill, and I'm lead counsel in the case of Fitch v. Maryland. That's a case where we have 48,000 state retirees trying to reinstate prescription drug coverage that was eliminated by this General Assembly. So it's we find it odd that at this point, we have this bill that proposes an application for waiver to the federal government to establish a program to find funding for healthcare for illegal aliens. The state eliminated prescription drug coverage for approximately 48,000 state and elderly retirees, and now they want to find funding for approximately 114,000 illegals. This does not make sense. You took an oath of office to swore to uphold the Constitution of Maryland, and you are not doing so. We have federal laws on the books in regards to immigration. They should be deported. No one should be able to work in this country illegally, yet it's happening. So why aren't you upholding the Constitution and your oath?
Thank you. And our last person on this panel is Mary Fry, and Mary has some help with, because she's hearing impaired, so you're going to have a little more time.
Okay, thank you, Madam Chair. My talking point come from the Federation for American Immigration Reform. This is not my personal opinion. This is fact. Obamacare was fully debated in Congress, and illegal aliens were specifically excluded from participating in government-run exchanges. even if they paid with their own money. For the same reason, Maryland should exclude illegal aliens from participating in state-run exchange. Under the Illegal Immigration Reform and Immigrant Responsibility Act of 1996, illegal aliens are generally barred from receiving federal-funded public benefits. Maryland taxpayers should not be on the hook to subsidize health care for illegal aliens. Even Cato, which supports illegal alien being allowed to work in the U.S., opposes taxpayer-funded health care for illegal aliens. Moreover, in a 2019 CNN poll, nearly 60% of Americans oppose taxpayer-funded health care for illegal aliens. According to a 2023 study by FAIR, which is the Federation for American Immigration Reform, approximately 350,000 illegal aliens and their 121,000 U.S.-born children cost the state of Maryland taxpayers $2.9 billion. If illegal aliens are allowed to participate in a state exchange, the cost to Maryland taxpayers would significantly increase. How can you provide free health care and drug benefit for 114,000 illegal immigrants who cross the border illegally and not take care of your very own, your state retirees? We work for you and the people of Maryland. You took money from us while we were employed, and that money was to go into the trust. I highly oppose Senate Bill 705.
Thank you. Do I have any questions for this panel? Thank you very much. We have one person virtually, and it's Mr. Ken Fitch. Thank you. Unmute Ken, and you have a minute. Thank you.
I oppose of this bill. I'm Fitch, as in Fitch v. Maryland. My name is Ken Fitch. I've been fighting for 6 years to reinstate the drug coverage for retired seniors, 65 and over. You didn't come up with no plan to try to fund them. Why are you trying to fund illegals? Who are you working for? Are you working for the citizens of Maryland? It's not right. You took an oath. You're not doing what you took your oath for. You should get out of office. Really seriously think about it. Stand behind your seniors who work for this, who earned this for years. Sum up the 48 years of service for the state of Maryland. And you want to try to fund it for illegals who broke in here illegally? Come on, get real. That's all I have to say.
Thank you, Mr. Fitch. So if there are no questions for Mr. Fitch, that ends our hearing for today on Senate Bill, I've lost the number. Thank you, Senate Bill 705. Mr. Chair, Mr. Sponsor, do you want to say anything in response to the funding question? I think we should clear something up.
Yeah, thank you so much, Madam Chair. I wish there was a disclaimer for hatred that was provided in this, but this is an opportunity, colleagues, for individuals who are working here in Maryland to purchase. Right now, they can purchase healthcare on a commercial exchange. This is simply giving them an opportunity, not the commercial exchange, but commercial insurance. They have a right because they're working here in the United States. They're paying taxes here in the United States. This gives them an opportunity to purchase. There's no subsidy. There's no cost to the state. This simply says to the federal government, give us a waiver to let these hardworking individuals, these new Americans, an opportunity to purchase insurance. That's the bottom line. That's all I have to say, Madam Chair.
Ends the hearing on Senate Bill 705. The next bill is my bill, Senate Bill 701. And Madam Vice Chair, I'm going to turn
This.
Thank you both for being here. No, you're.
Because it's your bill.
It's my bill.
Should have given you the, we apologize.
No, you're fine. Just happened to go here, wasn't it?
Yeah. Oh, it's interesting. Okay.
You have to bang the gavel.
Have to have a little quiet here. Madam Chair, take it away on Senate Bill 701.
Thank you. Thank you, Madam Vice Chair. Senate Bill 701 is the Maryland Health Benefit Exchange based on young adult health insurance subsidies pilot program. And I have with me Michelle Everly and Commissioner Brain. And so one of the questions we asked earlier was, how can adding more people reduce our costs for insurance? Well, one of the things we found out is we added young people with a subsidy that helped young people buy their insurance. We added more young people, and it was so successful, we ran out of funding. And so for 2 years, we didn't use all the funding. In the third year, we did use all the funding, but we can't go back and claim the money from those first 2 years where there was leftover money. So I believe what this bill does is it allows us to take money that was unused and use it in a future year. So I'm just going to be very brief and say that and turn this over to Commissioner Brain and Michelle Everly.
Thank you, Chair. Thank you, Vice Chair and members of the committee. Again, Michelle Everly, Maryland Health Benefit Exchange. This is hopefully a pretty simple bill. It is a technical change only. And as Chair Beidel said, this is a 4-year pilot program for the young adult subsidy. In the original bill, we had $20 million allocated per year. The first 2 years, we underspent and combined about $13 million. So there's $13 million left from the first 2 years. This year, we anticipate that the expenditure is going to be $22.5 million. What's driving that? One, we have done a lot of direct outreach and marketing to target the 18 to 34-year-olds. The public health emergency unwinding has moved a lot of folks from Medicaid into the commercial marketplace. And this year during open enrollment, we had a 41% increase in 18 to 34-year-olds. And in fact, about a third of our entire risk pool is under age 34, which is terrific for that risk pool. So the technical change will allow us to use the 20 million, which is the cap per year, plus, here's the change, plus any unspent funds from previous years. There is no impact to the general funds. This is reinsurance funding, which we already have, already been allocated for. So it just allows us to use the unspent money. Based on those facts, we ask for a favorable report on SB 701.
Good afternoon, Madam Vice Chair, members of the committee. Thank you again, Kathleen Brain, on behalf of the Maryland Insurance Administration. The sentiment is essentially ditto. This is a really critically important program in making sure that our risk pool is as healthy as possible. We've seen this be a really successful program. It's particularly increased because of the Medicaid unwind. We want to keep those people engaged. And so we don't want to run out of funding, and we don't want to have to prorate funding. We're estimating, as Ms. Everly indicated, about a $22 million to $23 million spend this year. So out of that 13 million that we haven't used, we would be looking to use that and then potentially in one additional year. In terms of our actuarial analysis of the health of the reinsurance program, this funding has already been assumed that this program would continue. So it will have absolutely no impact on rates. It will have no impact on the reinsurance pool itself. It will simply allow us to provide and keep those young people in for a longer period of time. Thank you. I urge a favorable report on this bill.
Thank you.
Questions for the panel? One question. Okay, Senator Reedy.
Thank you.
Where is, just out of curiosity, so there's money left over from 2 previous years. Where is that money now?
That money still resides in the reinsurance fund. So there's,
So it's in the
yeah,
fund.
it's in the fund.
So
It
there's
just
no-
wasn't used, but it's still in that fund.
Gotcha. It's not like in a rainy day fund at the state. It's, oh, great. Okay. Thank you.
Any other questions? Well, that ends the bill. Now we have three, Allison, Taylor, Stephanie Clapper, and Micah Bain. Okay, Allison, you want to go first?
Sure. Alison Taylor on behalf of Kaiser Permanente, me too.
Okay, and Stephanie?
Stephanie Clapper from the Maryland Healthcare for All Coalition. I just want to second everything that's been said already and also point out that thanks to your great leadership, young adults not only have newly enrolled in health coverage through the exchange more than ever before, but also are staying in that coverage, are able to buy better plans with lower cost sharing, lower deductibles. And it's also been improving health equity in our state. So I just want to thank the committee for your excellent leadership on this program. And it's been so successful that now this technical amendment is needed. So we urge a favorable report. Thank you.
And Mukta?
Good afternoon. My name is Mukta Bain. I'm a doctoral student at Morgan State University, pursuing my health policy and healthcare leadership. Thank you, Senator Vital, and the Finance Committee members. I'm here today to support Senate Bill 701, and I'm urging you guys to support this bill. My health insurance was covered by Medicaid. I was unsure regarding my coverage because I became a contact tracer during COVID at Baltimore County Department of Health, and they did not provide coverage for contract workers. So because of COVID-19 emergency fund, I was continued to be covered by Medicaid, but I wasn't sure for how long. So obviously I was very scared and stressful regarding my health insurance. While sourcing in Maryland Health Connections, I noticed the premium and the deductible was too high. And I had to choose either pay for my rent and pay for my therapy session or my medication, which is very unfair. Young adult age 18 to 34 are the highest uninsured age group in Maryland. Thanks to the leaders in Maryland who started and supported subsidies program to make health affordable for young adults. The program is widely successful that this technical change needs to be made. So everyone like me are eligible to apply for health insurance. This is very important that we all young adults are eligible subsidies and able to receive them. Let Maryland be an example for other states. And please, I ask for your support. Thank you.
Are there any questions for the panel? No questions? That ends Senate Bill 701.
Thank you. Next, we have Senator Guile, and she has one person on her panel, Andrew Collins.
Sure.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, Senator Dawn Guile, District 33. I have here with me the Assistant Adjutant General of the Maryland Army National Guard, General Andrew Collins, here to present Senate Bill 697. This bill would simply remove the $60 monthly cap on the health and dental insurance premium reimbursement that was established under the Healthcare for Heroes Act. Last year's bill established a TRICARE premium reimbursement program in the Maryland Military Department. The department may award grants up to $60 per month to a member of the Maryland National Guard who is eligible for TRICARE Reserve Select. Grants may be used to pay for premiums for TRICARE Reserve Select program or the TRICARE Dental program. Just quick background, TRICARE Reserve Select is a premium-based health insurance plan available for selected reserves members and their families. For calendar year 2024, premiums are $51.95 per month for an individual coverage and $256.87 per month for family coverage. Meanwhile, the TRICARE Dental program is a premium-based dental plan for National Guard Reserve members. For calendar year 2024, premiums are $12 per month, approximately $12 per month for sponsor-only coverage, up to $111 approximately per month for sponsor and family coverage. Because the $60 reimbursement covers only that of individual sponsor coverage, it leaves out coverage for family policies. So Senate Bill 697 is about extending the full benefit of healthcare for heroes to service member families. This bill is about lifting the financial burden of healthcare coverage for military families here in Maryland, and ensuring that those serving on the home front, including our National Guard families, get the health care that they need. I would therefore ask for a favorable report on Senate Bill 697. Thank you, Madam Chair.
Thank you. Go ahead. Thank you.
Good afternoon, Madam Chair and members of the Senate Finance Committee. My name is Brigadier General Andrew Collins, and I'm here today to speak on behalf of dedicated men and women of the National Guard and advocate for the cap removal of the Healthcare for Heroes TRICARE Premium Reimbursement Program. As a member of the National Guard, I can attest to the sacrifices that my fellow citizen soldiers and airmen make to ensure the safety and well-being of our great state and nation. Providing our Guard members and their families with affordable health care ensures readiness when we are called to serve our state and nation. Removal of the cap will have no fiscal impact on the FY25 budget, and I'm happy to answer any questions from the committee. With the cap removed, service members like Staff Sergeant James Whiting, a firefighter with the Maryland Air National Guard, said he would use the extra money from his reimbursed premiums to help fund his retirement savings. For other Guard members, the extra money would go towards daycare, gas for commuting to work, groceries, or college tuition for themselves or their children. I know firsthand the challenges of balancing military service and civilian life. The demands of the Guard often require service members to take time away from work and their families to serve their country. It is only fitting that we provide them with the support they need, including affordable health care. Governor Moore proclaimed 2024 as Maryland's Year of the Military Family. Providing health care for them is an important tool for recruiting and retention of Maryland citizen soldiers and airmen. Please consider this critical readiness issue for Guard members to be always ready and always there when the state and nation needs them. In conclusion, I respectfully ask the committee for a favorable report on the Healthcare for Heroes TRICARE Premium Reimbursement Program. Thank you.
Do I have any questions? Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, Senator, for this bill. General, I'm trying to follow your testimony. You said there'll be no cost. This bill have no cost to, was it to the member or the state? I'm not sure.
I think in reference to my statement, I was
Yes.
mentioning no fiscal impact to our FY25 budget.
Okay, no fiscal impact?
If I could just clarify, I do think, Senator, that there, according to the fiscal note, there is an impact for the state fiscally. But I think that's ultimately a policy decision as to, allocation of funds and making it a priority to provide healthcare coverage for family members of our National Guard.
Yeah, thanks. So I was trying to, break that down and looking at the fiscal summary. It's like 1.65 million for 25, 26 fiscal 27, 28 and to 29. So I was wondering if there would be like an offset, like a reimbursement of the reimbursement from the federal government. That's why you could say there'll be no effect.
No, there would not be a reimbursement from the federal government.
Okay. So that
This would be covering the premiums that would be paid otherwise.
okay, so the state will be picking
Yeah.
up the premiums
Right.
that the members would normally pick up.
Exactly, right. But TRICARE is a federal program, of course, but the premium burden would be on the service member and their family.
And so the cost to the state would be like 1.65 million per year, according to The fiscal
Oh,
note.
yeah, according to this, yeah,
Okay.
for fiscal note.
Okay, great. Thank you.
Thank you.
So Senator Guile, I have another question, just I
Sure.
support the bill, it's great, but
Right.
suppose someone has coverage in their employment and it's fully paid, or it's, you know, maybe even less expensive than this, would they then still stay covered in their employment, or is TRICARE just a better plan overall?
People can have both TRICARE, you know, it would, the government plan would always be secondary. But I guess some people, you could opt out and decide not to get coverage to that. So presumably if somebody's a Guard member and they are receiving insurance through their, through their employer, then they wouldn't necessarily have to get through this plan.
And I just wonder if that was taken into consideration in the fiscal notes.
It's a good question. I'm not sure. Thank
But,
you.
I'm sure that budget and tax will help us with that fiscal. note.
Yeah, thank you. Thank you, Madam Chair.
Senator Moss, you have a question?
So would this extend just to members of the reserve or all active duty?
No, active duty is covered under different, under TRICARE, completely different. This is for guard members specifically.
Would active duty have to pay a premium?
Well, no, I mean, active duty has their own separate coverage. In fact, active duty service member usually doesn't pay out of pocket for premium.
That's the essence of my question.
Yeah, exactly.
That's correct. It's covered under TRICARE Prime, which is fully covered. For
Yeah,
active-
or
active
TRICARE
duty
Select, just depending on what kind of program they opt to go into.
And does Virginia, Pennsylvania, Delaware, any of the surrounding states offer something like this?
Good question. Not sure. I can find out for you though.
Okay, thank you.
Thank you.
See no other questions, that ends the hearing. Thank you very much, Senator Goff, for the bill.
Thank you.
Senator, my Vice Chair, Senator Klaasmeyer, Senate Bill 633, Maryland Self-Service Storage Act. Shall I call up your panel while you're walking up, Senator? Bruce Bariano, Todd Snook, Marcin Bacalares, and Kevin Boggs is the panel.
I'll just stand up there. This time. You sit down.
Is Daniel Bryant also at the table?
Yes, ma'am.
Thank you, that's fine.
Thank you, Madam Chair. And esteemed members of the Senate Finance Committee. Good afternoon, Chair Bidle and fellow members of the Senate Finance Committee. I'm here today to present Senate Bill 633, which simply simplify the procedure under the current Maryland Self-Service Storage Act when there is an auction sale of property in a rental unit that is in default or been abandoned by the tenant. We've all seen those auctions, haven't we, on TV? They're kind of interesting. Under current law, I always wanted to do it, so now that I have some friends in the business, I might get a chance to do that. Under current law, the tenant has to first initial on the rental agreement before the owner operator of the self-storage business can advertise the sale of property from an abandoned or defaulted unit. Practically speaking, this can make things difficult for the business owner if the tenant cannot be found or had a bad relationship with the owner. Senate Bill 633 would make the advertising section in self-storage law consistent with 30 other states that permit modern advertising or have no advertising requirement at all. This will allow storage operators to choose how to advertise auctions in a manner that best serves both the operator and the former occupant. In practice, all occupants will still be contacted several times to inform them of any default before any sale is conducted. I would like to thank the committee for their time and ask for a favorable report of Senate Bill 633. And
Madam Chair, Madam Vice Chair, members of the committee, thank you for the opportunity to testify today. My name is Daniel Bryant. I'm with the National Self-Storage Association, which also manages the Maryland Self-Storage Association. Ask for your support today for Senate Bill 633, a bill to modernize the advertising requirements in the Maryland Self-Storage Act. Wanted to walk through some of the elements of the bill today. First, the current law does permit storage owners to advertise outside of the newspaper, but only if the tenant authorizes it in the rental agreement. SB 633 would allow storage owners to choose the method of advertising that they deem most appropriate, and customers would be informed of that in the rental agreement, which is contained in section 18-5034. Second, the bill in section 18-5043 would amend the required elements that must be contained in every default notice to include the method and location of the advertisement. This change would apprise the tenant of the location of the advertisement at a relevant time following a monetary default, as opposed to making the election at the time of execution of the rental agreement. As you'll hear from my colleagues today, the changes in Senate Bill 633 would make Maryland's law consistent with 30 other states that permit the storage owner to choose the method of advertising online or have no advertising requirement at all, like Virginia. Respectfully ask for your support for the bill, and thank you again for the opportunity to testify.
Who'd like to go next?
I'll go next. Madam Chair, members of the committee, thank you for the opportunity to testify. My name is Marcin Baklars, and I'm a regional manager in Maryland for Storage Mart. Storage Mart is the largest family-owned and operated self-storage provider in the United States with more than 300 facilities in 19 states. I ask for your support for Senate Bill 633 to modernize Maryland's Self-Service Storage Act. First, I want to dispel the idea of lean sales like the ones we saw on TV show called Storage Wars. Those are highly staged auctions. The overwhelming majority of the auctions do not contain gold coins or priceless artifacts. I wish they did. Most auctions contain leftovers belonging that the tenants functionally abandon and for the storage owner to clear out. Further, Storage Mart never profits from these sales. In rare instances, when there is excess proceeds, we return them to the owner to settle their debt. Storage Mart is a responsible corporate citizen. We accept pennies on a dollar for settlements for customers that cannot pay, and we do not pursue customers that cannot pay after the auction. We also voluntarily suspend action through COVID. Just to throw some statistics out there, in 2023 as a company, we had 4,750 auctions in the US, fewer than 16 per store. Average balance before going to auction on the accounts was about $790.21. The average sale price of a unit sold was $212.48. Storage Mart average loss was $577 per unit out of those 4,750 units. Once newspaper advertising fees are considered, the loss increases even furthermore. Overall, our company lost around $4 million on lean sales and we recovered about less than 27%. Thank you.
Madam Chair and Senators, thank you for the opportunity to speak today. My name is Todd Snook. I'm the owner of Valley Storage. We were founded in Hagerstown, Maryland. I'm a lifelong resident of Maryland. My son was a page here some years ago, and we love Maryland. We still base our business here. We operate 58 locations in 8 states, and I would like to ask for support of Senate Bill 633 to bring Maryland into 2024. Virtually no other state requires this. As my previous speaker mentioned, it costs the tenants money, it costs us money. There's no notification, there's no names in the auction advertisements. It's merely to generate bidders, and our online platform does generate 3 times the amount of bidders that any newspaper. In addition to that, I operate in small communities where some newspapers aren't even daily publications at this point. So it's really a moot point to advertise in the paper. Does not help the tenant. It does not help the operator. We have a very small piece of Washington County. So you may have a manager that works in Pennsylvania one day, Maryland another day, Virginia another day, and it's very much a burden and confusion. And we urge that you vote in favor of Bill 633. Thank you.
Good afternoon, Madam Chairman and committee members. I'm Senior Vice
President of Operations. My name is Kevin Boggs, and I work for Storage Mart. I have 13 states, and Maryland is one of the states that I help manage. Storage Mart, again, is the largest family-owned and operated self-storage provider in the United States, with over 300 facilities in 19 states. I ask for your support of SB 633 to modernize the Maryland Self-Storage Service Act. As a bit of background, our industry is not in the business of selling possessions of individuals or former customers. We are in the storage rental space business. Sometimes, however, sales are required when tenants do not make their pay their rent and to recoup their debt. More importantly, to return that unit back into a rentable unit for a paying customer. The law requires that our rental agreements apprise tenants in bold type to the existence of our lien rights and that the property may be sold to satisfy the lien upon default. Additionally, the law requires direct notices to the tenant before the sale to proceed. In practice, local managers do attempt to make calls multiple times prior to the sale, preceding the sale in various forms of communication, email, traditional mail, phone calls, text messages, etc. Resolving the non-payment issue in a way that does not require sale is always preferable to us, and rarely bring in maybe 30% of the amount of outstanding debt. Maryland law currently requires the operator advertise a sale in the newspaper of direct circulation before conducting it, unless it otherwise authorized by the tenant. Current Maryland law does not even require the publication of the tenant's name in the advertisement. Newspapers are outdated. I do urge you to modernize this bill, please.
Thank you. And Mr. Bariano, you're
Thank you,
last.
Madam Chair, member of the Senate Finance Committee. For the record, Bruce Bariano. I'm here on behalf of my clients. I've been representing these clients for about 35 years and know them very well. I want to thank the Vice Chair greatly for introducing this legislation. I wanted to come last because I just want to address my time period to the very unfortunate opposition which you're going to hear from the Attorney General's office. Very respectfully, what I at least see here and read shows ignorance of the industry and really suggests that my clients, who I've been representing a long period of time, are really fly-by-nights and charlatans, and they're out to rip off the public. And that bothers me. It really does. If you look at the current law, which is not in the bill, if you look in the current law, when a person comes in to rent a facility, they have to upfront sign a contract in bold print. This is current law, where they are told it's a rental agreement, that there's an existence of a lien, the personal property stored may be sold to satisfy a lien if the occupant is in default. Personal property stored is a lease space that can be towed or removed if it's a vehicle or something of that nature. And that the occupant, if they're in default for more than 60 days, then action would be taken. So what this bill does is, rather than require the occupant to authorize advertisement once they're in default or they may have left and we can't even find them, up front they're told of what their rights are, and there's a lien, and it's all in bold print, and they agree up front under this bill, rather than at the end that we can advertise and we can sell the goods. They want the space. They don't want what's in there. They're not trying to be in the business of selling merchandise. If there's a default, they're about renting property. And if the person leaves or they abandon it, and they do that sometimes, they can't use the space. Thank you very much. Would urge a favorable report. Thank you very much.
Senator.
If I don't know if you know this, Bruce, but I think one of these gentlemen would know it. If someone has all their junk in there and you can't get a hold of them, and what do you do with that stuff?
So I can speak for obviously the process that Storage Mart
Yeah,
has.
what is the process?
When we can't get a hold of somebody, we send them a letter, first letter of default by mail. Second letter that goes out sometime later is a certified mail. it's kind of above and beyond the current requirement, actually. We don't have to send a certified letter, but we do. And that letter does say the date of the auction and where that auction will be held.
Okay, so you always have an auction, you just don't throw things away.
We are not, no,
Oh, okay.
absolutely
That-
not.
that's
To
what I-
satisfy it, it has to go to auction first.
Okay.
Every single time.
Okay.
Now, if it doesn't sell at auction, we are allowed to otherwise dispose of. So if we run on the set date, if we run the auction and let's say unit doesn't receive any bids, nobody wants to buy it, then we allowed to dispose of it.
Okay. Do you ever give any like to Goodwill or anything like that, or just?
We try.
Yeah.
But I mean, it adds up quickly, month after month after month. So yeah, it's a constant task.
Okay, thank you.
Madam Chair and committee, I just wanted to say one man's junk is another man's treasure, just so that you know.
Give them my card.
Thank you very much.
Thank you. We don't have anyone else to testify, right? No? Okay, so that ends the hearing on Senate Bill 633. And now we're going to go to Senate Bill 791, Health Insurance Utilization Review. Again, Vice Chair Klasmeyer. And yeah. And your panel is Matt Celentano, Allison Taylor, Donna Kaufman, and Tommy Thompson. So if you'd like to come up.
Share a desire to. Good afternoon, Madam Chair, esteemed members of the Senate Finance Committee. Before I begin, well, Senate Bill 791, Health Insurance Utilization Review Revisions. But before I begin, I want you to all get your cameras out and take a picture of what we have here. We have providers, and we have the payer community, the provider community, all sitting together supporting this bill, which this is a testament to the work that we did over the interim to find consensus, recommendations, and come to you with a bill that we could all support. As you will recall, I sponsored a similar bill last session after a physician came into my office and told me a story of a patient who had successfully managed on her medication for manic depression. On reauthorization, the insurer denied the medication. Without the medication, the patient spiraled and consequences were tragic. In addition to hearing this and other similar stories, we also heard from providers regarding the time spent on the prior authorization process, which I will note is unreimbursed time, and how it was contributing to staff burnout and taking time away from patient care. Last session, the bill did not pass. Instead, under the direction of the chair of this committee at that time, a work group was formed to examine all of the issues raised and to develop consensus recommendations to bring to this session. I became involved during the beginning of the meetings. The meetings were inclusive and provided an opportunity for everyone to put their issues on the table. After a few minute meetings identifying the issues, we went to work drafting language. I can attest that no side loves this bill, but that is what makes it a good bill. We found middle ground that I believe has important protections for patients, reduces the burden that has been placed on providers, but still allows payers the ability to perform utilization review. I understand the health insurance is expensive, but we have to get what we have got to take steps to ensure that the story I heard last session and that we all have heard does not continue. We are always hearing of patient choice and self-directed care. we need to make sure that those principles are not lost for patients who need the care the most. Therefore, Senate Bill 791 strikes a reasonable balance that will begin to swing the pendulum back to a much more manageable process. Key highlights in the bill include ensuring that a patient who has been well maintained on a drug can remain on that drug if the insurance company originally approved it. The patient has remained on the drug and the prescriber attests that the drug continues to be necessary to treat the patient's condition. To me, this is essential. Again, I realize that healthcare is expensive, but there is nothing in this bill that prevents an insurance carrier from requiring newly diagnosed patients to begin treatments using a less costly drug. However, there is a difference between someone starting a new therapy and someone who has been treated with the drug for years and has been well maintained on this drug. I do not want to be responsible for a mother being taken off of a drug that controls her seizure only to risk her being placed on another drug that doesn't, or as I stated earlier, the patient with the bipolar or schizophrenic who has finally found the combination of drugs that help them, and then each year have to be told a different drug must be used. Other protections in this bill allow a patient who switches carriers to remain on a drug for the first 90 days of coverage while the new carrier conducts its own review and confirming that a prescriber can change dosages of the same drug without needing a prior authorization each time. Senate Bill 791 will also reduce delays that occur when a patient appeals a denial or when the medical necessity is being questioned by the insurer. Senate Bill 791 will also require that criteria and standards used by the insurance companies is based on known and accepted standards of care. This is very important for all the aspects, but particularly important for the behavioral health community. The bill also requires that if a carrier is issuing a denial, the carrier must tailor the denial letter specifically to the carrier and provide a detailed explanation of why the request does not meet medical necessity. If additional information is needed by the carrier to make a determination, that information must be specifically conveyed to the prescriber as what additional information is needed, such as a lab test or other diagnosed information. Lastly, the bill implements what is known as a real-time benefit check, which will better empower prescribers in making decisions. This check through an electronic health record will allow prescribers to see the exact insurance benefit available to a patient, which drugs require prior authorization, and the cost of each drug. Through the Maryland Healthcare Commission, we will also be reviewing how other states have implemented what we call the gold card standard and whether prior authorization should be implemented if a provider enters into a value-based contract. We understand that there are a few clarifying and technical amendments that have been brought to our attention by the Maryland Insurance Administration that we will be working on. We are also working on some additional study language for your consideration. In conclusion, I am pleased with the outcome of the work that was done last session and this interim to develop meaningful solutions to problems presented. I believe that this bill will provide patients with protections that they need, and it will begin to alleviate the burden on providers caused by the prior authorization process that has gone relatively unchecked for over the past several years. Thank you very much, and I hope we can pass this bill. And this is the sponsor panel. We have Matt Celentano, Allison Taylor, Dana Kaufman, and Tommy Thompson. So.
Thank you, Madam Vice Chair. Who would like to go first?
And thank you, Madam Chair, Madam Vice Chair, and members of this committee. I want to start with thanking Senator Reedy, who actually began this discussion in the Senate for the Maryland Psychiatric Society and the Washington Psychiatric Society, who I represent, because this barrier of prior authorization was having real impacts on the patients. And from that conversation, it led from a specialty group being picked up by our main group, MedChi, and I owe them a lot of thanks that we're now on a 30-page bill. And we went from no fiscal note to a large fiscal note for no apparent reason because the issue hasn't changed. But my gratitude to them and to the carriers who are at the table supporting these changes in law to help patients who are experiencing mental health crises to stay on the treatment that they are currently adhering to successfully is so meaningful because the losses that they experience are so abrupt. They lose family members, they lose their own lives sometimes, they become a danger to others, they lose housing, they lose employment. And that's all because they get destabilized, albeit for a very short period of time. But that period of time is meaningful, and that's what this bill addresses. This is a priority bill for the Maryland Psychiatric Society and the Washington Psychiatric Society. It's taken 4 years from that little bill that Senator Reedy introduced, and that now Vice Chair Klausmeier has helped us work on together with parties that could not see a resolution for quite some time to get to this point. So I'm very grateful to her as well. This is a consensus bill. I don't want to go into the merits of the bill. They're all there before you and you've heard them all before, but know that you are making a meaningful impact on mental health in Maryland by passing this bill if you pass none other this session. That's how important this bill is. Thank you, and I'll take any questions from the committee.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente, and I also want to thank my co-panelists. We worked really well together over the interim. It was a lot of tedious work, but we did a really nice job, and especially want to thank Dana for all the hard work she put into each draft of this. I want to call your attention to one of the provisions that Senator Klausmeier raised, which was the real-time benefit check tool, which I'm personally really excited about. It's a tool that will appear in the person's electronic health record, which will show the physician what their benefits are and what drugs require or do not require prior auth. So it's a good opportunity. We hope for I think this is a problem that's really well suited to a technology solution in addition to a legislative solution. So I'm happy to see that both are here. In case it comes up in another panel, I did want to point out that there is one provision in the bill that does not apply to Kaiser physicians in the way that they interact with the Kaiser health plan. There's an exemption that was actually requested by the Kaiser physicians because they already manage their own utilization review, prior auth, and reauthorization procedures. And so they wanted to continue with that. But if a Kaiser member goes to a physician that's not within the Kaiser network, then that law still applies, and everything else in the law applies to Kaiser too. So we had a favorable report. Thank you.
Madam Chair, members of the Senate Finance Committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in favor of Senate Bill 791. To be clear, we were opposed to the entire bill last year. We still don't love this bill. I'm still pretty sure that my colleague to the left, Ms. Kaufman, doesn't love this bill. But we just spent the last 15 months sitting at the table trying to work through these issues. And I can say that the fact that everybody up here didn't get everything they want and still don't like the bill should probably mean to you it's a good product and something the General Assembly can be proud of. It does definitely move the ball forward. And I want to thank everybody that was involved for a lot of work and a lot of meetings to get us a place where we are comfortable. So I urge a favorable report. Thank you.
Madam Chair, members of the committee, on behalf of MedChi and several other of our healthcare association members or clients, we are in strong support. We thank you for your support for this bill. My fellow panelists basically said it all. This was a very long process that we started off with two sides on opposite ends of the room, and we were able through over 11 meetings to come together and hammer out a solution, which of course didn't include all of the provisions that were in the original bill, but really does move the needle and swings the pendulum back so that physicians can be doing what they're supposed to be doing, and that is patient care. And then for the patients, of course, you've heard it, you're going to hear it some more, that reauthorization process, it is so vital to the patients and to the healthcare system overall. You often are hearing how the patients are put into jeopardy when they are required to go off of a medication that they were previously approved for and well maintained on. But there's also not just the issue of switching them off that medication, but there's the issue of the downstream risks that can occur or the downstream effects when somebody is taken off the medication and the underlying other medical considerations that occur, which could lead to increased costs with more lab tests, more doctor's visits, ER visits. So we believe that that provision is just so dominant in this bill and will really protect. And in the end, we do believe that it'll save the system money. So we request a favorable vote. We're very excited for this bill. And I know that our physician community is very excited for it as well. It's been a long time in coming. Thank you.
Senator Reedy.
Thank you, Madam Chair. That's definitely is great to see everybody coming to the table in an agreement. I gotta ask, and maybe Dana, if I can ask you, I remember my little bill that could like we mentioned a couple of years ago, and I don't remember I went back and looked, I didn't have any fiscal note on it. So why is there this? I don't understand this large fiscal note. Do you have any insight into why they would be saying it's going to cost the state money to this level?
So thank you for that question. I have been looking at that issue as well. The Department of Budget and Management did put a fiscal note on the state employee benefit plan. But I do want to also point out, you've heard it before, I'm going to say it again. The state plan is an ERISA plan. So it is federally regulated and it is not required to follow the requirements of this law. It may choose to, but it is not required. But more importantly, I do agree with the Department of Legislative Services that without specific data and a basis, which was not provided in the letter of information from the Department of Budget and Management, a reliable estimate cannot be determined because we do not know what the cost will be to the healthcare sector as a whole by not allowing or requiring somebody to be switched to a lower cost drug. And I will also point out too, that when you look at the appeals and grievance language, there are issues on the number of denials, which is about 95,000 this year, but there's also information about the complaint process and how often a patient is able to stay on their current treatment when it is reviewed by the Maryland Insurance Administration. But regardless of that, as the sponsor of the bill, Senator Klossmeyer, pointed out, we are sensitive to that issue, and we are looking at crafting a study to look at the effects of this bill in the next couple years. So that is an approach that this committee has taken before on other issues. You let the bill go into effect, you study it, you review it, and you use real data to see what the effect is and whether or not any changes need to be made. But the policy decision still needs to be put forward that individuals need to be able to be managed on a drug and remain on a drug that works for them and not be forced off of that drug. So that's the information we're going to get from the study. We've often heard before of bills where it was said we're going to have a large fiscal note or a negative implication, and that just didn't happen. So we look forward to working on that language, putting it before you, so we know then what changes we would need to be made with real data.
Yeah, it just seems to me that if you there's costs associated with people getting kicked off of their drug and having to have extra appointments and it seems like there's other costs that comes in with an inefficient system, which this seems to have gotten to. And so I would hope that also would mitigate some of any potential costs. But thank you, Madam Chair.
Thank you.
See any other questions for this panel, which is pretty amazing, but thank you all. There's no unfavorable testimony. We have a couple with amendments, but there's no unfavorable, so that's a good sign. Thank you all for your work. 11 meetings, that's
And
a lot.
I would like to thank Patrick Carlson as well, because he was there
Thank you,
with us.
Patrick. Next, we have Ann Seacott, David Lloyd, Melinda Duke, Dan Daugherty, Daniel Shattuck, and Michael Patty. Looks like everybody's here. Well done. Who would like to start?
Go. Thank you, Chair Vital, Vice Chair Klausmeyer, and members of the committee for the opportunity to testify on behalf of Inseparable, a national nonprofit focused on closing the treatment gap for people with mental health and substance use disorders. I'm David Lloyd, Inseparable's Chief Policy Officer, and have worked across the country to improve access to care through health insurance reform. We are proud to support Senate Bill 791, which is an essential step to addressing Maryland's mental health and addiction crisis. We are deeply appreciative of Vice Chair Klausmeyer and Delegate Collison's leadership, including bringing together stakeholders, including insurers, to reduce barriers to mental health and addiction treatment at a time of such overwhelming need. My written testimony provides details on critical provisions of SB 791, which I'll touch on briefly here. SB 791 includes the essential and common sense requirement that insurers conduct utilization review in a manner consistent with accepted clinical standards of care and using transparent, peer-reviewed nonprofit medical or clinical specialty criteria. This requirement aligns providers and payers around quality care. SB 791 also requires that coverage determinations meet specified timelines, and crucially, if an insurer fails to make a timely determination, the requested care must be approved. This gives certainty that insurers have to meet these timelines. Inseparable is grateful to Vice Chair Klausmeyer for introducing 791, and we respectfully request the committee favorably report this bill. Thank you for the opportunity to testify.
Thank you. Ann, would you like to go next?
Was it Ann or Dan?
Ann.
I'm happy to. Ann Seacott, on behalf of the National Council on Alcoholism and Drug Dependence, in favor of Senate Bill 791. We just want to say we are appreciative of the process of folks coming together. And we're especially supportive of the patient protections that are in the bill that will make sure that essential behavioral health services, substance use and mental health services are not inappropriately denied. So we thank you for all the work, and Senator Klausmeyer for your support.
Thank you. Now we'll have Dan.
Madam Chair, members of the committee, I'm Dan Shattuck here today on a variety of the healthcare clients that we represent. This bill, as has already been said, is a consensus bill. It really will help a number of our clients in the interactions that they have with their patients. It really, ideally, will remove a lot of administrative barriers that have been faced. And you've seen our testimony over the years about practices having to hire individuals where their sole focus is to administer the prior authorization requirements and handle appeals and denials and so forth. So really, I think what this bill does when you synthesize it down is it addresses where the medical decision-making between the provider and the patient interacts with the health plan management. And I think this bill is going to go a long way to making sure that that interaction is not a collision, but more of an intersection where what needs to go through easily will go through easily. What might need a second look gets a second look. But all in all, to keep the process moving, because at the end of that interaction, it really is how it impacts the patient. If they're going to stay on their medication, if they're going to get an extension of their services. So it's really bringing, I think, to a head, and I'm looking forward to the studies in the future to see what further tweaks that need to be made. It's all about getting the care that the doctor, the provider, and the patient determine is best. Get that taken care of with a healthcare plan and whatever coverage is out there, and just keep moving things along, improving outcomes, improving health, and hopefully reducing cost on the back end. Let's not let the administrative barriers create more healthcare problems and healthcare costs. Thank you.
Thank you, Dan. Melinda, you want to go next?
Thank you. Good afternoon, Chair, Vice Chair, and committee members. I have 27 years of experience caring for children with diabetes who require insulin for life. The administrative time suck into the blender of prior authorizations and reauthorizations and denials takes away important time from patient care, education, and emotional support. Changing a medication that was previously approved because of an insurance requirement is often scary for a patient or family that has become familiar with how the medication looks and works for their child. Families deserve continuity to continue medications that are familiar and that are working well. Isaiah, an underserved teen with diabetes that struggled with OCD, sought help from a mental health provider. As his issues were being addressed, his previously well-controlled diabetes suffered. For nearly a year, every new medication that was tried required multiple adjustments of his insulin pump settings from me. Isaiah's mental health provider explained the restrictions placed on his treatment plan by the insurance company did not allow him to stay on the OCD medication that worked. Patients should not be treated as silos. There are rarely a single diagnosis. And the part of the health team that dictates what medications we can use should not either. We can and should do better for all the Isaiahs in Maryland. The members of the Nurse Practitioner Association of Maryland want to provide care, education, and support to their patients. All too often, an inordinate amount of time is spent letter writing, making phone calls, waiting on hold to obtain or continue a medication that already works. For these and many other reasons, I personally and as a member of NPAM wholeheartedly support HB 791.
Dan.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Dan Doherty. I'm here on behalf of the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. I want to echo what my cohorts have said about the hard work everybody put into this, about the great role that the Vice Chair, as well as Delegate Kerr and Delegate Cullison on the other side, did in getting us all together and working on this. I've heard a lot of people say that, you know, it's a compromise, nobody likes it. Let me say this, I've been here long enough to know that when a bill goes in, you get 5 or 6 things that help, you like it. And we like this bill. It will shorten timeframes in getting review of denials, which will free up staff time, dentist time. We're always talking about problems with a lack of access to dental care. This may be one of the effects of this bill. There'll be more time for the dentist to treat patients. So for this and a lot of other reasons, we urge a favorable report on Senate Bill 791.
Thanks, Dan. And finally, Michael.
And Michael Patty here today for the Maryland Community Health System, a network of federally qualified health centers across the state in support of Senate Bill 791. The bill essentially gets boiled down to transparency, streamlining the process, and reporting. And we support all 3 of those things. This bill moves in the correct direction. For that, we support the bill. Thank you.
Thank you all very much. Do I have any questions for this panel? Thank you for your testimony. Thank you for maintaining your 2 minutes. You did great. Next, I have 4 favorables: Morgan Mills, Julia Roche, Margaret Schnitzer, and Aaron Maury. And then I'm going to bring up 2 favorable with amendment: Heather Forsyth and Tricia Swanson. Is Morgan here? Morgan, we'll start with you. Thank you.
Awesome. Thank you so much. Good afternoon, Chair, Vice Chair, and members of the committee. Thank you so much for the opportunity to testify in front of you today. My name is Morgan Mills, here today on behalf of NAMI Maryland. We advocate for persons with mental illness and individuals with lived experience. Very pleased to be supporting SB 791, which helps address patient access issues as it pertains to utilization review standards. Navigating the healthcare and insurance system is already difficult, especially for individuals seeking mental health care. The process can be very overwhelming, and additional barriers on top of that exist for people with mental illness. Because the process is so overwhelming, when patients receive denials, in some instances, they find it very difficult to appeal. While we support the entire bill, I want to share a story related to medication renewal. As you've heard, there are instances of carriers issuing denials for medication renewal, even when they previously approved it and the patient is successful on the drug. Here I have several emails from a psychiatrist in the state detailing the arduous process he had to navigate for a patient that was on a drug, doing well on the drug. Time came for a renewal and it was denied. The psychiatrist tried to appeal. It took quite some time and the patient started rationing his medication. The psychiatrist still couldn't get through to the review agent. He was spending hours at a time on a general call line. All the while, the patient was suffering. Eventually, the issue was addressed and the denial was reversed, but imagine what would have happened had this patient's treating psychiatrist not been a devout advocate for him. This is of increased importance for mental health care because psychiatric medications influence brain chemicals. And so if patients have to ration or stop suddenly, this has adverse effects on patients. With that, I end my testimony. I thank the bill sponsor for these efforts, and I'm here for any questions. Thank you so much.
Thank you. Julia?
Is it already? It is already on. Good afternoon, Madam Chairwoman and members of the committee. My name is Julia Roche, and I'm here to voice my support for Senate Bill 791. I'm a resident of District 40. He's gone. And I am here testifying on behalf of myself. This is a really important bill. In particular, I want to stress the provision that would allow people with chronic conditions to remain on the medication that works for them rather than be forced to switch by their insurance provider. Almost 50% of people in the US have a chronic health condition, and this number is growing. Chronic conditions include autoimmune disorders, asthma, heart disease, diabetes, Alzheimer's, many mental health conditions, and more. I myself have a chronic condition that I manage with medication. After a COVID infection in 2021, I developed an autoimmune disorder. I was in extreme discomfort almost all the time for months. I didn't know what was going on, and it was the scariest thing I've ever navigated. Thankfully, after a lot of trying, I found a good healthcare provider who was able to diagnose me and treat me with a steroid. It took almost a year, but my condition finally went into remission. I use that steroid routinely to keep my condition in remission and will need to do so for the rest of my life. One day, I got a letter from my insurance provider. It told me that one of the steroids I had taken was no longer covered. Thankfully, it was one that I had tried that didn't work for me, but it could just have easily been the one that did work, the one that I use today. I am acutely aware that I may one day get a letter saying my treatment is no longer covered. If that happens, I don't know what I'll do. As we get older, it becomes more likely that we'll develop a chronic condition. So if this bill isn't yet relevant to you personally, it's likely that it eventually will be. I urge you to consider my testimony and the other favorable testimony you've heard today and vote favorably on Senate Bill 791. Thank you.
Thank you. And I hope you're wrong about that future.
I hope so too.
Is Margaret here? Thank you.
Madam Chairwoman and members of the committee, thank you for allowing me to testify in support of Senate Bill 791. My name is Margaret Schnitzer, and I have been the director of the Baltimore City Health Department's Community Asthma Program for the last 11 years. I'm testifying on behalf of the Baltimore City Administration in support of this bill, especially as it relates to prior authorization and allowing people who take medication for chronic conditions to continue to use the medication that has worked for them. Our program works with children who have moderate to severe asthma. These children often end up in urgent care centers and hospitals when their asthma cannot be managed and they literally cannot breathe. Our job is to help these children and their families get a better handle on their asthma management. Asthma is a complicated chronic disease that affects about 1/3 of Baltimore City high school students. Successful asthma management relies on using the most effective medication for that child. I've seen firsthand the struggles that families face when asthma meds are changed, especially when they are changed for non-medical reasons. A medication that doesn't work can leave children gasping for air and petrified. Imagine breathing through a coffee stirrer. That is what it's like when you have an asthma episode. Prescribing asthma meds is both a science and an art. At last count, there are 22 daily medications with at least 7 different delivery methods. Finding the best medication for a child can take lots of trial and error. In addition to which medication to prescribe, medical providers must consider other factors, such as the child's age and physical capabilities. Can they breathe in deeply and quickly? What's their hand-eye coordination? Are they able to hold their breath? This is not a determination that should be made by an insurer. This bill allows children to stay on the medication that works for them. This is the medication that they know how to use and when to use. The one that allows them to play with their friends, go to school, and live a life without being scared that they're going to die from their asthma. I'm sure this is how you would like your children to live if they had a chronic disease that was being successfully controlled. We are hopeful that you will vote favorably on Senate Bill 791. Thank you.
Aaron? Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members. I'm Dr. Erin Maury. I'm here on behalf of MedChi. I appreciate the opportunity to speak in support of Senate Bill 791. Our goal is to protect the sanctity of medical decisions made between a doctor and their patient and streamline the delivery of healthcare. As a rheumatologist, I treat autoimmune diseases such as lupus and rheumatoid arthritis. Our medications can be life-altering. When the right medication on the verge with the right medication, patients on the verge of disability can return to work. When that medication is changed due to formulary changes, it's like having the rug pulled out from under you. If a new drug doesn't work, that patient could be looking at disability again. I've seen this and many other such scenarios happen too often. It can take 4 to 6 months for a drug to start working and up to a year to be fully effective. If the drug is denied on reauthorization due to formulary change, I'm forced to change to a drug that may or may not work. Our diseases can progress while waiting 4 to 6 months for this new drug to work. If it doesn't work, the damage from autoimmunity accelerates and may not be reversible. Returning to the previous drug may not work because the immune system can reject it, just like you can reject a transplanted organ. Our drugs cannot be switched in and out like Advil and Aleve. For example, a construction worker with psoriatic arthritis had been doing well, but was forced to switch to a different drug. His disease worsened. I tried switching him back to the previous drug, but the body rejected it. The next drug I tried worked okay, but not well enough for him to avoid going on Social Security disability. He is now permanently disabled and can't even do basic handyman work at his own home. Treatment changes not controlled by the patient's doctors can have serious consequences. As a physician, it's hard to manage my patients and keep them at work and have a decent quality of life when treatment decisions are taken out of my hands. MedChi and the insurers have worked together over the last year on Senate Bill 791 to address these issues. I ask that you support Senate Bill 791 to improve the quality of patient care in the state of Maryland. Thank you.
Thank you. Is Heather Forsyth here? Would you, if you can squeeze in there, or you can go up to the podium, it's fine. Thank you. So Heather's favorable with amendment.
Yeah, favorable with amendments. It's awfully tempting to just say ditto for all the very good testimony that you heard this afternoon. But for the record, I'm Heather Forsyth. I'm the Deputy Director of the Health Education and Advocacy Unit at the Attorney General's Office, offering comments in support of this bill. The changes that this bill proposes should help eliminate delays in care, reduce inappropriate denials of medically necessary care, and reduce administrative costs for healthcare providers. Insurers will frequently point to utilization review protocols as key to controlling healthcare costs, but as you've heard, overly stringent policies not only prevent patients from obtaining the necessary care recommended by their healthcare providers, but often any short-term savings for the insurers get shifted downstream as increased costs to other parts of the healthcare system. We provided in our written testimony additional data and many consumer stories about the burdens of overly restrictive utilization review protocols, so I won't repeat them here. But just to say that these stories are not unique and highlight the frequent problems faced by both consumers and providers. All of that notwithstanding, we do really appreciate all of the work that the stakeholders did during the interim. MedChi, the insurance carriers, our Maryland carriers, our legislative members, and this final draft is largely reflective of that work. We did have some minor, largely technical amendments and suggestions, which we've shared. And hope they'll be perceived as friendly amendments. They're also enumerated in our written testimony. We look forward to working with the stakeholders, and we hope and thank the committee for a favorable report on SB 791. Thanks very much.
And our final testimony is with Tricia Swanson.
Yes, good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Tricia Swanson on behalf of Care First, here favorable with an amendment. I wanted to start my testimony by echoing those that spoke before me and thanking Vice Chair Klausmeier for her hard work on this issue over the years, in addition to the Chair and the Finance Committee for all of your work on this very important issue. We agree with so many portions of this bill, with a large chunk of this bill, and we acknowledge and appreciated the work over the interim to come up with a bill that we believe will improve access. We did have one concern. It was noted kind of in the question of the prior panel. This MHCC study we believe is incredibly important. It's a balance between the consumer benefit and the consumer cost. And in particular, because Care First participates in every market in Maryland, in every county in Maryland, and we insure the most people in Maryland. We don't have a PBM like the other insurers. And as you heard, Kaiser is exempted. So we believe that our members might be hit the hardest by this. And so this study, we believe, is incredibly important. As a chartered not-for-profit mission is to provide affordable and accessible healthcare. We have a unique perspective on ensuring the maximum benefits reach people at a cost that's affordable. And what is driving these costs? This committee knows too well. It's prescription drug costs. And I want to reiterate a fact that this committee heard, and it was referenced during the PDAB hearing. Pharmacy costs are the leading costs of healthcare. Currently, 35 cents of every healthcare dollar is going to prescription drugs. And this is the single largest cost category. And this number has more than tripled over the last 20 years, and it will continue to grow. Prior authorization is one of the tools that keeps prescription drugs affordable. And it's incredibly important that we keep this tool. Care First has been a leading advocate for prior authorization improvements, and we've been working internally and externally in partnership with large hospital systems and healthcare practitioners to advance interoperability. To conclude, we applaud the work that's been done on this bill by all the stakeholders, and we'd urge a favorable report with the MHCC study language. Thank you.
Thank you, Tricia. Do I have any questions for this panel? Senator Hershey, you're trying to put your light on? There you go.
Thank you. Thank you very much, Madam Chair. And Tricia, just on the last part, you spoke about the amendment. Care First was part of the work group, correct?
Yes.
Okay. And did you proffer this amendment during the meetings of the work group and discuss that with them? We're just saying if we kept hearing that this is a consensus bill and people, like things, don't like things, but this was finally the way to move forward, I would just think one of the major players in Maryland would have been able to work this out during the work group.
Yeah, and I do wish we would have, because I do, as I said, Care First supports so much of this bill and agrees with so much of this bill. Unfortunately, this wasn't raised as a big issue for Care First until a month or so ago. It's a large company. It's hard to get feedback from my people internally. And so we're incredibly apologetic for that. And that's why we're here hoping to study the language, but acknowledging that we need to improve our internal processes to that effect.
Can Care First live with the bill if it doesn't have this language in it?
We would have large concerns with passing a bill without a study to look at that reauthorization language.
Okay. All right. Thank you very much. Thank you, Madam Chair.
I actually have a question for Dr. Maury.
Yes.
It's nice to see you again.
Yes, you too.
I had an issue with a family member that was not having success on a certain medication. And the doctor did a blood test and found out that medication would never work for her, that she was missing like folic acid or some enzyme, and was able to switch the medication based on that blood test. How often does that happen? And is that an easier way than putting people through trial and error?
It would be great if we had those kinds of tests for all of our drugs, but we only have one test or one or two tests. I think I know what you're talking about with the folic acid deficiency. But that one is not, most of our drugs do not have that test. I would love to have that. So thank you.
That's good to know. Maybe that comes in the future. Are there any other questions for this panel? Thank you very much. And that ends the hearing on Senate Bill 791. And we have our last bill of the day. And I see that it's Senate Bill 93. And I see that Senator Augustine is here. And do you have a panel? Are these? I do. Is it Ann Seacott, David Lloyd, Christina Green, and Ellen Weber?
Yep.
Okay, everybody please come up.
Is Dr. Jones on the list, Madam Chair?
No, should Dr. Jones be on the list?
Apparently.
Okay, well, that's fine. When I come
right.
to your committee, I can have the same.
Oh, you know
courtesy.
you'll get that.
Thank you.
You know that. Thank you, Chair Vital, Vice Chair Klausmeyer, and members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 93, Health Insurance Utilization Review, Private Review Agents. Folks, you just heard obviously a very big and a very important bill on utilization review. This bill is far more focused on behavioral health, and you'll hear about that, but it is still in the same space as the utilization review. And this bill requires private review agents to adopt best practices and the criteria and standards they use in health insurance utilization reviews relating to mental health and substance use disorder benefits, providing clear rationale linked to established criteria before issuing an adverse decision, and specifies the procedure private review agents must follow when making decisions about mental health, substance use disorder benefits. This we find to be, you'll see in my written testimony, I've got information here about the linkage between this and the Parity Act, that Parity Act where we want to make sure that we are treating behavioral health and all of the surroundings of it in the same manner that we treat somatic care. And so that's why we felt like it was very important to hold this piece of legislation up separately to that, with certain guardrails that are associated with it. Now, what this bill does, as I mentioned, it makes sure that we utilize best practices and the criteria and standards that are used by health insurance utilization reviews, and then it specifies procedures private review agents must follow when making those decisions, and then provide a clear rationale linked to those established criteria. Like that's just like the piece of this that is just clearly the most important. And what I will say to you all is that, I mean, just based on all the work that, the vice chair and others have done in the utilization review, this bill was pre-filed. There was an understanding, a working of sorts to take a significant part of the language that is here into that bill. We're really grateful for that. And so we also have an amendment which should have been provided to the committee that adopts that similar language into this bill to what was in the broader utilization review bill. But then it also does still include some additional guardrails and things that we think that are just very important, that again, very specific to the space of behavioral health, which you will hear from my panel. So with that, I will ask for a favorable report on Senate Bill 93 as amended. Thank you.
Chair Vital, Vice Chair Klausmeyer, members of the committee, thank you for the opportunity to testify in favor of SB 93. I'm Ellen Weber with the Legal Action Center. Insurance coverage is only the first step to help Marylanders with mental health and substance use disorders recover and maintain their health. Access to care is essential, and it's the utilization review standards that determine whether an individual gets the right care at the right time or not. So SB 93 addresses both what the right standards are, as well as fidelity in the application of those benefits. So the right standards for utilization review are those developed by the Nonprofit Society of Medical and Clinical Practitioners. That is the exact same standard that's in SB 791, which we fully support, and we are grateful for the inclusion of that, Senator Klausmeyer, in the bill. SB 93 would address fidelity in two specific ways. Again, and these complement SB 791. The first thing that it does is it would require private review agents to explain to the practitioner the criteria that a patient does not meet before issuing a denial. And preventing incorrect denials is essential for prompt access to affordable care, and it will also reduce the administrative burdens that often deter mental health practitioners from joining networks. Less than 1% of patients challenge mental health or substance use disorders, but 37% of those denials are overturned on appeal. So pre-denial determinations will allow for immediate corrective action. And then the second piece that's essential is that SB 93 would require agents to authorize care for a patient's underlying chronic condition rather than approving treatment just based on their acute symptoms. Families around the country have sued carriers for denying rehabilitative care to their children based on the need for acute symptoms. Carriers don't require a person who has suffered a heart attack to have continuing acute symptoms in order to get the care for their chronic condition. The same should apply in the mental health context. We thank you and we urge a favorable report.
Thank you, Ellen. Who would like to go next? Go ahead.
Feel free. Oh.
Thank you. Thank you, Senator and Chair and Vice Chair for having me today. I represent Luminous Health. My name is Dr. Leah Jones. I'm the Executive Medical Director for Behavioral Health Services there. We stand in support of this legislation because of all of the things that you've heard about so far. One of the things that Ellen was trying to enumerate before she ran out of time, I was talking about using standardized criteria, particularly for not just the acute phase of a person's illness, but for the chronic phases or the more intractable parts of their condition as well. And so one of the criteria that we use in the treatment for substance use disorders is the ASAM patient placement criteria. And by their medical necessity criteria, they expressly state that you're not looking just at the acute phases of the illness, but also the underlying conditions that perpetuate the disease of addiction as well. As we know, only 10% of people who have substance use disorders actually are able to access treatment. We don't need more barriers to care. We need everything that we can do to make it easier for people to access care, resources, and services. And certainly if people are being denied services, or if there's a threat of denial, there should be an opportunity for the providers to know exactly what the criteria are that the denial is being based upon, so that we can make more appropriate and so that we can advocate more fully so that patients can have access to the care, treatment, and services that they deserve and that they need. This legislation would level the playing field for people who have private insurance to the standard of those who have public insurance, which is actually a better cover and provider for behavioral health care services. And this legislation will help to level that playing field and make it easier for people who have private insurance to actually get the full amount of care, treatment, and services that it is that they need, that their peers are able to access that they are not able to access. So I thank you for having me. I'm happy to be with the panel and to support this legislation, and we hope for a favorable review. Thank you.
Thank you, Dr. Jones. Anne, would you like to go next?
Thank you, Madam Chair. Ann Seacott here again on behalf of the National Council on Alcoholism and Drug Dependence, the Maryland chapter, in support of Senate Bill 3, really for the reasons that have been stated. This is about making sure that there are really tight standards and standards of review, standards of criteria used in determining whether or not someone should be able to access the services they need. We very much thank Senator Augustine for bringing the bill, and we ask for a favorable report.
Thank you. David Lloyd.
Thank you, Madam Chair, Vice Chair, and members of the committee. Again, David Lloyd, Inseparable's Chief Policy Officer. We strongly support SB 93 and appreciate Senator Augustine's leadership. SB 93 is a very strong bill that will increase access to mental health and addiction care, and we believe complements SB 791. As my fellow panelists have already shared, a very important provision would be that requiring insurers to explain why criteria or guidelines that are required were not met before they issue a denial. Once a denial is issued, very few people, appeal those denials, and so effectively, the denial of care sticks, and they're not able to get the treatment that they need. Also echo that it's critical that for what are oftentimes chronic mental health and substance use disorders, that people get ongoing services and not have those services inappropriately limited to just acute short-term treatment that just treats often their symptoms and doesn't actually treat their underlying conditions. So we're proud to support this bill, and thank you for the opportunity to testify, and hope you favorably report this bill.
Thank you, and you must be Christina.
Yes, thank you. Hello, Madam Chair and members of the committee. My name is Christy Green, and I'm the Executive Director of Maryland Coalition of Families. We are testifying today in support of Senate Bill 93, submitted as also our written testimony. Last year, we served over 4,600 families of a loved one with a behavioral health need. I am here today representing our families' voices. One struggle our families face is denial of coverage and or claims from private insurers regarding behavioral health treatment. Access to coverage for behavioral health care should be treated equally. When there is no explanation as to why it is denied, it leaves the family and individuals searching for options and answers, making it difficult to find treatment and sometimes exacerbating the crisis the individual is already experiencing. This leaves an increased risk for relapses and potential harm. One example is a family we served whose child needed intensive treatment and care due to multiple suicide attempts, substance use, aggressive behavior, and was a victim of sex trafficking. While inpatient, the private insurer began to deny the claims for coverage. Due to not being able to return home safely because of risk of harming himself or others, the parent had no choice but to take on the hefty bill. The parent appealed many times and still received no explanation as to why the claims were being denied. They were in constant contact with the insurance company and the medical board. In some cases, families are willingly relinquishing custody by signing a voluntary placement agreement and or children in need of assistance agreement to ensure their child receives the mental health care they need because of denial of claims or coverage from the private insurer. This is systematically dysfunctional and costly. The families already have the fight of their lives. Why make them fight this too? Uniform utilization review criteria will help Marylanders who are struggling to access mental health services. Thank you for letting me testify today.
Thank you very much. Do I have it? Oh, Senator Ellis.
Thank you, Madam Chair. And thank you, Senator Augustine, for this bill. Very important topic. I have two questions. My first one, maybe to you, Senator Augustine. So looking at the committee testimony, and it seems like the insurers don't like this bill. In your humble opinion, why do you think that is?
Well, first of all, there is another, as I mentioned at the outset, a significant bill, Senate Bill 791, which is a lot of work that's gone into that, without a doubt. And as a pre-filed bill, the original bill that was put forward was the language was not worked out in the way that it was in 791. But like I mentioned, I have put forward the amendment that matches that, and it just has the additional parts with it. So they had not seen that this bill would be in that way, and that agreed to language for that significant part of the bill. So I would imagine that is a part of what would be their objection to the bill.
So, okay, are you saying that after you heard like their objections, you kind of worked that in to this bill?
Well, no, it was actually being worked on as it was going, right? But it wasn't a part of this pre-filed bill. So this bill was pre-filed. It had certain very targeted information that pertained to behavioral health and substance use disorder. Okay. The other bill was much broader. It covered the whole spectrum. We wanted to be really targeted and focused because this is an acute problem in and of itself. Okay. But some of the language was adopted. Much of the language from this bill was adopted with certain changes, which we then took, which is kind of like worked out for 791.
Okay, yeah, great. Thank you, Senator. And Ellen, so you talked about denial of care, and in other states lawsuits were filed, and you just left there. I mean, were they successful, or
many of them,
about that?
Excuse me, Senator.
No,
speaking of the mic.
Oh, excuse me, Senator. Yes, in many situations they were successful, and what they were finding in many of these cases is that two things happened. First, the criteria were simply overly restrictive in a way that only looked at a patient's acute symptoms. And that was not consistent with generally accepted standards of care. There was a major case against United Healthcare in which that was the finding, that United Healthcare developed utilization review criteria that put its financial interests above the rights of patients to get benefits. So that's one response. A second way in which some of these cases are successful is they do this comparison, as Senator Augustine mentioned. There's a parity compliance issue here. There are standards that are applied for medical conditions that are far less rigorously implemented and applied than for substance use disorders and mental health conditions. And so when there are disparate disparate standards and disparate application, those are situations in which patients have been successful.
Great, thank you. And thank you, Madam Chair.
Any other questions for this panel? Thank you very much.
Thanks.
I have one unfavorable. Allison Taylor from Kaiser Permanente.
We're over 2, Allison.
Hi, good afternoon, Madam Chair, members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente. I respectfully in opposition only because the bill we support on this topic is the Vice Chair's bill that we heard right before this one. And it does include, as was discussed, a lot of the language that was in that one has been moved into that one. So that's the reason for that, but that's it.
Do I have any questions for Ms. Taylor? And you are our last witness for the day, and that
Okay.
ends the hearing, and that ends the day committee. Thank you.